Um, Good morning. Welcome to the Ceylon College of Physicians Specialty Update Series. So from this year, each month, the Specialty Update Series is done in collaboration with one of our sister societies or colleges. And this time it is the Sri Lanka College of Gastroenterology. We have an excellent lineup today of speakers who will talk on many aspects of gastroenterology. May I now invite Dr. Sanjeev Arya Singha, who is president of the Sri Lanka Society of Gastroenterology, to introduce the speakers and get on with the session. Sanjeeva, over to you.
Thank you, Professor Senaka. Good morning, everyone. And on behalf of the Sri Lanka Society of Gastroenterology, let me warmly welcome you to this CCP Specialty Update Day. We have organized this 2-hour session into two main parts. The first 1 hour will be devoted to a liver symposium, and we have 3 speakers for that. Following which, we have 3 other lectures on standalone lectures of different aspects of GI disease. So we'll start off the liver symposium, and our first topic for discussion is non-alcoholic fatty liver disease to metabolic associated fatty liver disease, Nafl to Mafl, in other words, if you use the acronym, approach to managing fatty liver disease in 2021. And it's my great pleasure to introduce our speaker, Professor Madhunil Niriyalla from the Faculty of Medicine, University of Kelaniya. Over to you, Madhunil.
Thank you, Chairperson, sir. Good morning to the participants. I'd first like to thank the Ceylon College of Physicians and the Sri Lanka Society of Gastroenterology to coming together to organize this symposium. And the topic that I have been given today is from Nafl to Mafl, approach to managing fatty liver disease in 2021. I have no relevant conflicts of interest to declare. And in the next 19 minutes, I'll try to go quickly through the current definitions, the pathophysiology, disease burden, risk factors, and outcomes of Nafl, and concentrate more on staging of the disease and the current management of Nafl, and wind up by discussing some do's and don'ts in the management of Nafl. The current Nafl definition includes the need for demonstrating hepatic steatosis, or the presence of more than 5% of liver fat that is commonly detected on imaging and very rarely on, less commonly on histology. And there is a highlight here that this should be in the absence of a secondary cause. And the secondary cause of most importance is the exclusion of unsafe alcohol. So the patient will have fatty liver, but also will have safe or no alcohol intake. And the cutoffs for the Asians I have given here, less than 14 units for a male and less than 7 units per week for females. And there should be no competing cause for hepatic steatosis, such as steatogenic medications or hereditary liver diseases like Wilson's, and no coexisting other chronic liver disease to account for the fatty liver, such as chronic viral hepatitis, mainly hepatitis C, and autoimmune hepatitis. So fatty liver disease, or the non-alcoholic variety, has a spectrum of disease from simple steatosis to steatohepatitis to NASH-related cirrhosis. The simplest form is the non-progressive, or the less severe variety is the simple steatosis, where there is fat with mild inflammation, but there is no fibrosis. And this is the most common variety that we see in clinical practice, accounting for about 75% of the patients. Less than that, 25% of the patients will have the more aggressive form of the disease, that is steatohepatitis with fat deposition, with inflammation and hepatocellular injury and fibrosis. So this is the more aggressive form of the disease. This, with time, can progress to NASH-related cirrhosis, and that will show bridging fibrosis and nodule formation. From more recent data, we know that there is a possibility of simple steatosis progressing rapidly to cirrhosis. And this is highlighted now in the management, that we need to identify these patients early to intervene to prevent cirrhosis. What about the pathophysiology? There is a complex pathophysiology of Nafl. I have tried to summarize it here. There is altered gut microbiota, oxidative stress, and lipotoxicity within the liver, that will cause and propagate fatty liver disease. The altered microbiota is dysbiosis. And what we mean by dysbiosis is there is loss of the natural variability of the gut microbiota, as well as the harmful bacteria being more and the good bacteria being less. And there will be lipid accumulation and hepatotoxicity within the liver, and this will also be to add on to this injury, there will be oxidative stress causing inflammation and liver fibrosis. And this usually occurs in an individual with genetic predisposition, and these genetic predispositions are commonly single nucleotide polymorphisms, which I have listed here on the left side. And in this genetically predisposed individual, through unhealthy lifestyle practices, fatty liver can progress from childhood to early adulthood to adult to old age. And these unhealthy lifestyle, there are two main types, that is the diet and sedentariness or low habitual physical activity. Initially, the disease will have no symptoms, but with time, about 20-30 years down the line, the patients can present with cirrhosis. And throughout the illness, there can be increased cardiovascular risk. A little bit more detail how this the lipotoxicity or the fat accumulation in the liver occurs. There is insulin resistance is the mechanism that drives the fat accumulation in the liver. This is mainly through muscle insulin resistance and insulin resistance within the white adipose tissue. What about the epidemiology of Nepal? We know that it's a global epidemic. Worldwide, 25% of the worldwide population, the adult population, will have fatty liver. And this is alarmingly more higher among the diabetics, with twice that prevalence, about 55%. And the more aggressive form of fatty liver, the NASH, occurs in the general population in about 5% of patients. And if you see the diabetics, it is about 7 times more common among the diabetics. So NASH in diabetics account for about 35%. Epidemiological studies done in Sri Lanka have demonstrated that there is about 1/3 of the adult urban population suffers from Nafl, and the annual incidence is about 6%. What are the risk factors? The modifiable or the dynamic risk factors and the non-modifiable static risk factors. The static ones are age, gender, ethnicity, and genetics. And the modifiable ones are obesity, sedentary lifestyle, poor diet, insulin resistance diabetes, dyslipidemia, hypertension, and obstructive sleep apnea. Some of these are clumped together to define the metabolic syndrome. So we know that some patient groups have fatty liver more than others. Morbid obese patients presenting for bariatric surgery, about 90% of them will have fatty liver. Diabetics and obese patients can have up to 70% of fatty liver, and metabolic syndrome and dyslipidemia, about 50% of them will have fatty liver. The other way around is also true. Having Nafl predicts future metabolic disease. Having Nafl will have about 2 times the risk of future diabetes, heart disease, kidney disease, and cancer, colon cancer in males and breast cancer in females. Therefore, fatty liver associated metabolic dysfunction is common. Having fatty liver predisposes to metabolic risk factors in the future, and those who have metabolic risk factors will develop fatty liver. However, the term non-alcoholic fatty liver disease does not reflect this current knowledge of the close association between the metabolic syndrome and its components and the fatty liver disease. So, metabolic dysfunction associated fatty liver disease, or MAFLD, is being suggested as a more appropriate term to describe this disease. In the table, I have listed the requirements for the definition. So, demonstration of liver fat by imaging or histology is required for both definitions, but the new definition does not require alcohol consumption exclusion, viral hepatitis or other chronic liver disease exclusion, or secondary cause of fatty liver exclusion, but it requires the presence of obesity or diabetes or other minor metabolic risk factors. So this is the new definition in diagram form. So first we must demonstrate hepatic steatosis in an adult. If they are either overweight or obese or have diabetes, one of them, they automatically become having MAFLD. The cutoffs for the Asians is more than 23 BMI. So if they don't have diabetes, if they are non-diabetic, and if they are not overweight, meaning if they are lean, we need at least 2 of the minor metabolic risk factors, and those are central obesity, hypertension, high triglycerides, low HDL, prediabetes, insulin resistance, or subclinical inflammation. We know from studies, prospective studies done in our setting, that there is a big overlap between these definitions. If you apply these definitions to patients with fatty liver, there is about 80 to 90% of overlap. Only a minority of patients are outliers. But the importance is that those who are defined by Nafl but excluded by the definition, compared to the Nafl excluded people, do better, meaning that Nafl definition, those who are excluded by the Nafl definition have a poor outcome. So this disease defines, or Nafl rather defines, a better population with adverse outcomes. So what are the outcomes of fatty liver disease? We know that compared to simple steatosis, NASH has about 5 times the risk of mortality. And it's important to recognize that this mortality is not predominantly liver disease, it is predominantly cardiovascular. And the second commonest cause of death is also not liver, it is cancer-related. Uterine cancers, breast cancers in females, colon cancer, prostate, pancreatic cancer in males. So the third commonest cause is liver-related death. We know that more than having NASH, the presence of fibrosis is the strongest predictor of all-cause mortality as well as liver-related mortality in liver disease. So therefore, we come to the staging of fatty liver disease. Once we diagnose, we must stage the fatty liver disease by showing how much of fibrosis is there in the liver. And how do we do this? We cannot do this by ultrasound. Simple ultrasound will miss a lot of fatty liver because if we apply the 5% definition cutoff, the sensitivities and specificities are very low. The ultrasound can only detect about 20 to 30% of liver fat. Once that 20 to 30% exceeds, the radiologist will be able to easily diagnose fatty liver, and CT actually does worse. So how do we look at liver fibrosis? There are wet tests or serological assessments. The two most commonest that is used is the Fib4 score and the Nafl fibrosis score. Fib4 uses the age, platelet, and AST/ALT. The Nafl fibrosis score, in addition to those four, will have the BMI, diabetes, and albumin. If I take Fib4 as an example, once this is calculated, this can be easily calculated with a smartphone with the app. And if it is less than 1.3, the score, there is a good negative predictive value, meaning it rules out advanced fibrosis. If the score is more than 3.25, it rules in advanced fibrosis and further assessment is needed. In between scores, between 1.3 and 3.25 is indeterminate, and we apply other tests to look for fibrosis. And what are these others? These are dry tests or image-based testing, and it's mainly elastography, looking at the stiffness of the liver. There are 3 main types: vibration-controlled transient elastography, or more commonly or popularly known as FibroScan. Then there is shear wave elastography and MR elastography. The most practical would be the FibroScan because it's a point-of-care test. It's relatively easy to perform, relatively cheaper compared to MR elastography, which is the best mode, but we can't apply it in clinical practice routinely, so we go for FibroScan. So based on these, the dry test or the serological assessment, followed by the wet test, first by the wet test, serological test, followed by the dry test, the image-based test, we can apply this to our patient care. In the primary care setting, all patients with Nafl should have a fibrosis screening by Fib4. If the Fib4 is less than 1.3, they can be continued to manage in the primary care setting with lifestyle modification. If they have a Fib4 score of more than 1.3, there is a possibility that they have high or intermediate fibrosis. Please refer them to the specialist care centers for the hepatologist to have a look. They will decide whether this patient needs a FibroScan or not. And once the FibroScan is done, depending on the liver stiffness measurements, we can again say they are at low risk of having fibrosis and can be referred back to the primary care. Or if they have high risk of fibrosis, they can be either looked for the features of established cirrhosis and managed in the cirrhosis care pathway, or if they are inconclusive, they might be subjected to a liver biopsy. And the liver stiffness measurements, which is expressed in kilopascals, that are for interest here, is the cutoffs is that if it's less than 8, it's low risk of fibrosis. If it's more than 8, it's indeterminate or high risk. And if it's more than 12, it is suggestive of cirrhosis. So we come to the current management of Nafl. So as I said earlier, cardiovascular disease prevention is the main management aspect in these patients. An appropriate gender-specific cancer screening should be done, and liver-directed therapies are the least important out of these three. And we have discussed that Nafl is a multi-system disease. There is insulin resistance, diabetes, obesity, metabolic syndrome, cardiovascular disease, and also chronic kidney disease. So these patients are ideally managed in a multidisciplinary setting. So multidisciplinary care clinics for Nafl. And this will involve the expertise of a hepatologist, diabetologist, cardiologist, internal medicine specialists, dietitians, lifestyle coaches, GPs, nephrologists. So this input is important because in order to manage these patients, we have to address all these issues to improve the patient outcomes. Lifestyle modification is the cornerstone of management of fatty liver disease patients. So if we get the patient to lose weight, about 3%, we can get rid of the fat. If we get the patient to lose weight about 5%, we get rid of the ballooning and inflammation. About 7% weight loss will result in NASH resolution. And if we get them to lose more than 10% of the weight loss, even the early fibrosis is reversible. That's very important. This study is from Cuba. It's a landmark study in Nafl NASH, showed that early fibrosis is reversible. The problem here is, if even this was applied, these aggressive lifestyle changes were applied for a period of 1 year, and not all patients were able to achieve this 10% weight loss, and those who achieved 10% weight loss were unable to sustain weight loss. That's the problem with lifestyle modification. It is the ideal treatment, but it's difficult to achieve and difficult to sustain. For lifestyle modification, what do we need for weight loss? The targets are 7 to 10% at least weight loss for overweight and obese patients, and half of that for the lean patients. We don't need that much of weight loss for already lean patients. The lean patients, although they are lean by BMI, they will have some degree of central obesity. They will have, if you carefully look at them, they will have a tummy. They will have an increased waist circumference. The diet that is recommended is a hypocaloric diet. The definition is there should be at least 600 kilocalories deficit from the daily requirement. Minimize the saturated fatty acid intake, including red and processed meat, and commercially produced fructose consumption by these sugary beverages. Moderate carbohydrate intake with low fat and foods with low glycemic index is recommended. Just cut out the carbs as much as possible. Encourage fruits and veggies. Regular physical activities should be encouraged. If it is moderate intensity, about 150 to 300 minutes for a week. And if it's vigorous intensity activity, about 75 to 150 minutes. Any exercise is better than no exercise. What about bariatric therapy? I think the second speaker will talk on this more, so I won't go into detail. Bariatric surgery and bariatric endotherapy both is very effective in achieving up to 10% weight loss. And this weight loss will result in histological improvement as well as resolution of fibrosis. But at present, the guidelines do not recommend bariatric surgery or bariatric endotherapy as sole indication to treat NASH patients. But of course, if they have other indications and also have NASH, such as if they have BMI more than 40, please refer them for weight loss therapy. And if they have 35 BMI with comorbidities, yes, they can be referred. But as sole treatment for NASH, bariatric interventions are not recommended at present. But I feel that probably it will come into the guidelines later on. What about liver-directed therapies? The targets are complex, but they can be grouped as metabolic, anti-inflammatory, and antifibrotic. The drugs that have been looked for looked at in clinical trials are many, but most of them have fallen short of expectations. And what we have at present are all off-label. None of the regulatory authorities have approved these treatments as treatment for NASH. So they are off-label. The FDA or the EMA have not recommended or not authorized use. So pioglitazone can be considered in diabetic patients, liraglutide also in diabetic patients. Vitamin E can be considered in biopsy-proven, non-diabetic, non-cirrhotic patients. The evidence comes from Pivens in adults, tonic for children in vitamin E, again Pivens for pioglitazone and lean for liraglutide. And all these drugs are not long-term. The trials have tried them out for about a period of 2 years. The importance of this is that if you have patients who are failing to achieve the lifestyle targets, you can give them time by giving these drugs for them to achieve the lifestyle targets. And these drugs should be prescribed very carefully because they are not without their side effects. For example, pioglitazone carries the risk of bladder cancer, worsening heart failure, and vitamin D given in the high doses can result in hemorrhagic strokes and prostate cancer. So these drugs are not for the long term and only for very selected patients with established liver fibrosis in whom we want them to achieve lifestyle changes and give them by time. The new kid on the block, or not so rather new kid at the moment, this study came out in 2019. The Regenerate study looked at obeticholic acid. It's a fascinoid X receptor agonist or a bile acid analog. And in a phase 3 multicenter randomized control trial, obeticholic acid at 25 milligrams for a day, not the pediatric doses that are described in our country, 25 milligrams improved fibrosis without worsening NASH, and that this was histological outcome. There were significant side effects of pruritus and atherogenic lipid profile, that is worsening HDL and low HDL and higher LDLs along the line. There was this concern whether it increases cardiovascular disease, but we don't have the clinical outcomes yet. This trial is still ongoing, but it seems promising. And saroglitazar, I thought I should mention. This drug was looked at in an Indian study. It was only an observational study. It was not a randomized control study, but it showed promise because given for 6 months, it improved transaminases, LSM, and CAP scores and glycemic control and lipid parameters in diabetic dyslipidemics with Nafl. So this was only observational. It shows promise, but we need more evidence from clinical trials. So what are the do's and don'ts? Do encourage patients with Nafl to engage in regular physical exercise. Prescribe a hypocaloric weight-reducing diet. Emphasize alcohol abstinence. Although the definition of Nafl has safe limits, for managing these patients, there is no safe limit of alcohol. Alcohol should be the patient should completely abstain from taking alcohol because alcohol will only propagate liver fibrosis. Coffee, we know, as hepatologists, we like to promote coffee consumption, and this coffee should be black, without milk, unsweetened, drip coffee, 2 to 3 cups for a day. Not 1 cup, 2 to 3 cups. That's a considerable coffee consumption. Unfortunately, we don't have evidence for tea. Promote adequate sleep, 7 to 8 hours. Use statins to treat associated dyslipidemia without fear. Although these patients might be having high AST and ALT, it's quite safe. Aggressively treat the metabolic comorbidities because that is what kills these patients mostly. Please do not perform fibroscans in all patients in Nafl because it's not indicated. Do not perform liver biopsies too liberally. Be very selective. Don't forget to screen metabolic comorbidities in these patients. Do not use metformin and statin as sole therapy for NASH, but use them if there are other indications. Please do not use ursodeoxycholics to treat Nafl patients. There is no evidence. And also, various liver-related nutritional supplements in the market have absolutely no place in managing these patients. You need to cut down the nutrition in these patients, not supplement it. And don't use liver-directed therapies such as vitamin E in all patients with Nafl. They should be prescribed only for selected patients with established fibrosis. So in conclusion, Chairperson Sir, Nafl is an epidemic. Recognize fibrosis as the main predictor for bad outcomes. Nafl is proposed as a better descriptor of the disease. Employ a two-step approach to help triage these patients and direct them to specialist clinics when needed. We know that transient elastography best rules out advanced fibrosis and is very useful in clinical practice. Ideally, these patients should be managed in MDT Nafl clinics. Management of the cardiovascular comorbidities should be the priority. Lifestyle modification to achieve target weight loss remains the cornerstone of management. Bariatric surgery at present cannot be recommended as sole therapy. Vitamin E, pioglitazone, and obeticholic acid can be used in very selected patients. And future therapies are in development and show promise, but still they are not ready for prime time. So in the population, in the community, what we want is to shift patients with obesity and sedentary lifestyle and bad dietary habits to more physically active, lean patients who consume healthy diets. If we do that, the consequences of this Nafl epidemic we will not see in the future. Thank you.
Thank you very much, Professor Niriela, for that excellent talk and keeping us up to date on Nafl. We shall keep the questions to the end of the liver symposium and go on to our next topic, which is endotherapy for metabolic disease, fact or fiction. The lecture will be delivered by Dr. Nilesh Fonandapulle, who is the senior lecturer and consultant gastroenterologist of the Faculty of Medicine, University of Colombo. Over to you, Nilesh.
Thank you, Dr. Sanjeeva. And I would like to thank College of Physicians for inviting us to deliver this gastroenterology update. So topic given to me was endotherapy for metabolic diseases, whether it's a fact or a fiction. You've just heard a comprehensive lecture on the metabolic diseases, especially the liver part of it. And I just thought I'll associate the word pandemic with it. Because it's probably one of the most commonest used words these days, and probably more than the novel COVID virus, metabolic disease probably has higher numbers and are killing higher number of patients. So it's something that we need to be really concerned about. And if you actually look at numbers, probably there are about more than 1 million deaths annually with patient type 2 diabetes, more than 500,000 deaths due to CKD, and about 200,000 deaths due to liver-related cancers and cirrhosis. So how do we manage these? So generally, broadly, we would manage this by lifestyle modifications. There's pharmacotherapy and surgery. And of course, today's topic is endotherapy. So before I actually go into the argument of whether it's a fact or a fiction, I would like to just, since endotherapy is probably something new also for Sri Lanka, I would like to just broadly introduce endotherapy, what are the different aspects of endotherapy available. So generally we divide endobariatric therapy, we usually call it EBT, into the gastric interventions and the duodenal interventions. And we have got space-occupying lesions, the intragastric balloons, transpyloric shuttle, full sense device, these are some trade names. You get the aspiration therapies, then you get the duodenal interventions where you get duodenal mucosal resurfacing and diversion techniques similar to what the surgeons do, gastric bypass sleeves. And also we have the gastroplasty techniques, which is probably the the important one which I will talk about. Right, just a bit of description, very simple. I'm not going to talk too much about these topics, different techniques. The space occupying lesion is basically an intragastric balloon where it's a silicone or polyurethane balloon filled with about 400 to 500 depending on the population of water with methylene blue. And it basically works in a mechanical effect with it reduces gastric emptying and early satiety. It's a OPD procedure done with minimal, probably a little bit of sedation, but patient usually can go home the same day. And what are the numbers? It usually it's kept for 6 months. It's usually not kept more than 6 months because of the risk of leaking and migration and obstructing the small bowel. At 6 months, the weight loss is usually about 10 to 21% with a median of 12%. It has shown to reduce fasting blood sugar, HbA1c, the cholesterols, thyroid stimulating hormone levels, waist circumference, and blood pressure. So it's something which is useful, but it also has some side effects. The commonest side effect that people do complain is digestive intolerance. So the patient, actually the one that we inserted, said that after putting it, he felt like as if he ate a biryani daily. So it was probably very full every day. So he was not able to eat too much. Another complication, severe dehydration, perforation, and sepsis in gastric outer obstruction are the more rare side effects, which we don't see too much now. But the problem with these intragastric balloons is, once you remove it after 6 months, if the patient is not motivated to reduce weight further, they will gain that weight back. And more than 25%, only about 25% of patients would have that weight loss after 2.5 years. And at 5 years, it's even less. So that's one problem that we have with intragastric balloons, the long-term maintenance of the weight loss. So which patients should we use intragastric balloons? It's probably used as a bridge therapy for definitive surgery, and also patients who need moderate weight loss. So people with we define as class 2 and 3 obesity, we can use intragastric balloons to reduce their weight, and also with combination of lifestyle modifications. Of course, these are approved by the European and the American regulatory bodies. This is our experience. One of the patients we did in 2019, end of 2019, a 37-year-old patient who had a weight of 122 kilos, BMI was 43, and he had lost about 9% of weight at 3 months, and 19% of weight at 6 months. So actually, this was a very good success, for a very good procedure. I mean, this is an isolated case, of course, but we had good nutritional support from the nutritionists who were very, very diligently following up the patient and making sure he did not eat unnecessarily. And so this gained quite good numbers for this patient. And even after removing the balloon at 1 year, patient still kept on losing weight, and he has a BMI of 33 at 1 year. So this was actually a very good success story for intragastric balloons, especially in a Sri Lankan setting. The other device that I want to tell you is what you call full sense device. So basically, it's like a stent, like a esophageal stent with a fully covered esophageal stent with a cylindrical component of the gastric cardia, which basically compresses the gastric cardia. So gastric cardia has been known, if you actually stimulate it, has been known to produce early satiety. So basically, what this device does is has a pressure effect on the gastric cardia and induces early satiety. Of course, these are not yet used freely in patients. These are probably more in experimental level. The transpyroid shuttle, a very simple thing, a space occupying device, where again you get two balloons, and the large balloon is in the stomach and the smaller balloon is in the duodenum. So when the smaller balloon with the peristalsis gets pulled, the large balloon sits at the pylorus, and similar to the balloon that I described earlier, has a mechanical effect, and it can reduce gastric emptying and prolong and early and induce early satiety. So these are kind of devices which use mechanical effects as space occupying devices to reduce weight in patients. These are another interesting technique, the aspiration therapy. Similar to the PEG tubes that we use, it's actually done through a PEG tube. You insert a PEG tube to the stomach, and this aspiration is done. So after 30 minutes after eating, 30% of patients' gastric content is sucked out and through this tube. And it obviously reduces the chyme and available for the absorption in the small intestines. And these has resulted in total absorbed the food intake, and even behavioral changes have been induced by this procedure. So what are the numbers there? It has been probably after 1 year, there have been probably about 19% weight loss in patients who use this aspiration technique, compared to 6% weight loss in the people who had lifestyle modifications. And this was sustained at 2 years. And it also had good metabolic effects. We reduced the triglycerides, HbA1c, LDL, HDL, and also reduced blood pressure. And this is also something which has been approved by the FDA for this group, the 35 to 55 age group patients who don't undergo surgery. The duodenal interventions which I spoke to you about is this duodenal mucosal resurfacing. In endotherapy, the duodenum is considered a very important area where the duodenum has been known to be able to control the metabolic effects in our body and also inflammation. So if we actually modify the mucosa of the duodenum, it has been shown if you can make it from a unhealthy to a healthy mucosa, it has been shown to have a lot of metabolic effects. So going with that theory, through different modalities, these are hydrothermal ablation. So basically you insert an endoscope and this balloon is in the duodenum. Up to about 3 to 12 centimeters of the duodenal mucosa is basically ablated or burned through different mechanisms. You can use it with hot water, or you can use it coagulation methods also. And basically the re-epithelialization would induce better metabolic effects. So the hypothesis was mucosal remodeling may hypothetically reset the duodenal enteroendocrine cells that are being diseased, thus restoring signaling that can improve diabetes control, potentially through an incretin effect, where it basically improves insulin sensitivity. And this has been shown to reduce HbA1c numbers by 1.2% at 6 months. This is without actually losing weight. So the weight loss has been quite moderate. And it also reduced the ALT levels, because we were talking about NASH in our previous lecture. So this has been shown to reduce even non-alcoholic steatohepatitis, induce any damage to the liver over the long term. And of course, the exact mechanism how this glycemic control occurs is still under study. Similarly, gastric bypass sleeve, or what the trade name is endobarrier, is similar to what happens in surgery, the Roux-en-Y surgery. There is this Teflon inner lining which lies from the duodenum or the pylorus, and for 65 centimeters down the small bowel, it basically creates a mechanical barrier that allows food to bypass the duodenum and the proximal jejunum. And so the food does not get mixed with the pancreaticobiliary secretions and only reaches the small bowel at a very later level. And that has been shown to reduce weight by 12 to 20% at 22% at 12 weeks, 24 to 30% about 24 weeks, and even long term at 52 weeks, there have been significant weight loss. The duodenal interventions are probably the real metabolic interventions where you use where it induces metabolic effects without actually reducing much weight, whereas the gastric methods causes weight loss and thereby induces the metabolic effects. The endoscopic sleeve gastroplasty, which is probably the more the technique which is probably used most and also probably has probably a good future, and kind of revolutionized endobariatric therapy. So basically, this is a endoscope which has a suture mechanism similar to a sewing machine, I would say. And so basically, you can suture the greater curvature of the stomach and make it into the stomach into a small volume. And these are X-ray or fluoroscopic image where the stomach volume has been reduced by creating an endoscopic sleeve. This is quite a safe technique. I'll talk about the side effects, but takes probably about 45 to 60 minutes, of course, in expert hands. And it is quite a lot used in America and also North America and South Africa, and also in European countries, and also in our neighboring India. So what are the numbers there? There is about 17% weight loss at 12 months. The BMI has reduced by 5 to 6 points at 6 months and 1 year respectively. And the importance of this technique is that it doesn't actually alter the anatomy. In the sense, it doesn't alter the blood supply, it doesn't alter the nerve supply. So the stomach is intact. Stomach mucosa wall is all intact. Unlike the surgical techniques where the anatomy is altered. So in case you need a re-intervention, you need to do something, you can redo the sleeve gastroplasty one, because the stomach is still intact. So basically, this is an image where you basically suture the stomach, and there are different plication techniques or designs that we use. So you can basically reduce the greater curvature of the stomach and reduce the volume of the stomach. Right. So that's basically an overview of the endoscopic bariatric therapies which are available for to manage metabolic diseases. So let's come to the question of that we the initial question that I was given, whether it's a fact or fiction. So let's see what are the available treatments available treatments at the moment for managing metabolic diseases. Lifestyle interventions, which is obviously the first line treatment which is offered to all patients, but only about 10 to 20% of people achieve that 7 to 10% of body weight loss, which even Prof. Madhuri Nidiyal was talking about in the previous lecture, which is needed to reduce the NASH or the fibrosis. Probably lesser weights are probably is as good enough, but if you actually target 10%, lifestyle interventions only manage to reduce in about 20 to 20% of the people. And the long-term maintenance of that weight loss needed to reduce cardiovascular events are also not maintained in lifestyle interventions. What about pharmacological therapies? Again, the numbers are very low. 3 to 9% of people lose weight with lifestyle therapies compared to lifestyle therapies alone. And these, of course, the side effects of weight reduction therapies, as you know, are a lot. So people don't like to take, and they are unfavorable, and people don't usually like to take these therapies most of the time. What about bariatric therapy? Probably the most effective and durable treatment option available for obese patients at the moment. And there are different techniques which are available. You get the laparoscopic sleeves, you get the Roux-en-Y bypass, you get the adjustable gastric bands, vertical gastroplasty, duodenal switch, biliopancreatic diversion. So there are different techniques used by the surgeons as metabolic treatments. But the numbers who actually need bariatric surgery and actually get or do have the bariatric surgeries are low. So it's only probably less than 1% of the obese subjects who qualify for bariatric surgery will actually undergo these interventions. So the numbers are very small. What are the reasons? Possible reasons. Probably the surgical cost is high. Maybe it's just the patient's preference, does not want to undergo surgery, and maybe access is poor for patients. And morbidity and mortality is also significant with surgical interventions, although over the years the numbers have reduced. And generally the early and late adverse effects have been as high as 17% with bariatric surgeries. So what we need is a less invasive approach to weight loss, which can actually bridge lifestyle modifications and pharmacotherapy with surgery, and which also has improved access. And also, the initial theory was to reduce weight loss, it was a mechanical restriction or malabsorption that was required. But now the pathophysiology of this weight reduction has been found to be much more broader, and there has been gut neuroendocrine signaling, there have been changes in GI motility, autonomic nervous system signaling, bile acid production and absorption, and even the dysbiosis, which can be targeted by these novel endoscopic therapies to create what we do at bariatric surgeries, and to give an effective treatment for obesity in selected patients. So it's not just the reduction of the food that we eat, but is also more targeting the physiological aspects of weight reduction, where we can actually help patients to reduce weight. Right. So is endotherapy a fact or fiction? I would say it's something that is definitely has a place in managing metabolic diseases due to its reduced invasiveness. It is reversible. It can be repeated. It's cost effective, and of course has better access. And it's generally used in class 2 and 3 obese patients. And the thing that we should not forget is this does not replace surgery. There is no competition between surgeons in this for endotherapy. It's basically we are complementing what the surgeons do. So what endoscopic or endotherapy does is a completely separate area. So class 2 and 3 in obesity, whereas the surgeons would be definitely dealing with the more the patients who are BMI of more than 35 with the comorbidities, or with the BMIs more than 40, and the endotherapy targets the lesser BMIs. So there is definitely no competition here. It's basically complementing and giving better access to patients who do not have access or do not like endobariatric surgery. So hopefully this will be used in managing obesity patients in the future. Thank you.
Thank you very much, Nilesh, for that excellent lecture and opening our eyes to the future of gastroenterology. Again, we shall keep the questions to the end and we shall move on to the next topic. The next topic is the management of a cirrhotic patient on the transplant waiting list, which is a very common scenario in our clinical practice. And we see what the physician should know. To give this talk, we have Dr. Mananjal Senanayaka, who is the consultant gastroenterologist at the District General Hospital, Nagoda, Kalutara. Over to you, Mananjal.
Good morning, everybody. Thank you very much. So I have been tasked with talking about the management of cirrhotic patient who's now already decided for transplant. Now this patient already needs transplant, but it's not happening at the moment. So how should we manage it? This is actually what we normally have to do. So for all the registrars out there, I have summarized a slide which has the crux of all what that I'm going to talk about. So this is my summary slide. So as you can see, if we take this analogy, now the liver or the boat we have is really not seaworthy. It's just not good enough. We would like a new one. We have probably spoken to a transplant center and they have said, yes, it'll be good to have a new boat, but they don't have a compatible one at the moment. So usually I feel that I am the person with the bucket, usually trying to funnel water as fast as I can. And usually the patient and the relatives are the ones who are sitting down under the umbrella asking, what is good to eat for this situation, despite this sort of overall scenario? So this is actually the proper summary. So what we have to do is maintain and improve the nutrition. We have to avoid further decompensation, avoid alcohol, smoking, avoid unnecessary drugs like NSAIDs. And we have to make sure they don't get a hepatocellular carcinoma, because then that will change their prognosis on the transplant list. And they are going to have decompensation. Now we have to do all these things to keep them alive. Bleeding, ascites, and KEF. I'm not talking about hepatorenal because we had an excellent lecture last night. And then we had to prevent this scenario called acute on chronic liver failure, which will also denote a very poor prognosis. And finally, we have to communicate with the family and the patient about the expectation and really how feasible this is. And I have to thank the College of Physicians for asking me to speak about these, especially in the time of 20 minutes time. Thank you. First of all, nutrition. So what is good to eat? So what is important is actually that there is a lot of malnutrition. It's a frequent complication of cirrhosis, even in the West, and it's associated with poor outcomes after transplant. About 20% of compensated, 50% of decompensated patients are malnourished. So actually there'll be a loss of fat and muscle, sarcopenia, but there's a strong association that it causes progression of liver failure, encephalopathy, ascites, risk of infection. So this is something we can do. Right. So this is a busy slide. Basically, it shows how all sorts of things contribute to malnutrition. There's a leptin metabolism change. It's a very complicated picture, but the summary is that our patients will be malnourished. And from this, actually, it's taken from a summary slide from Journal of Hepatology. Basically, what they are saying is don't give unnecessary dietary regulations and don't restrict protein. So I thought it's important to discuss with all our colleagues that although the causes for malnutrition are multifactorial, due to diet, asking them to take low salt, things like that, but low protein diet is not something we should be recommending. Everybody should stop this practice of low protein diet. What is interesting is normal and even high protein diets are now shown not to precipitate encephalopathy in trials. Even if the patient has encephalopathy, and the moment the patient has recovered, he should and can take oral, he should be started on normal protein diet. Yeah. So why we have to ask this is because although we give good instructions, patients who have cirrhosis are pretty depressed. Patients who took alcohol are sad that they took alcohol. The patients who are cryptogenic are unhappy that all their friends, actually they tell me, like the friends make fun of them. They say, we took so much alcohol, but you're the one who has cirrhosis now. So therefore they go doctor shopping asking what happened? Are you sure? Why do I have cirrhosis? All these things. So somewhere down the line, somebody's going to say, some MO, somebody's mother's cousin, somebody was going to say, I'm not too sure, but I think there's something about protein, better to be a bit on the safe side, which is wrong information. So we have to actively tell. So actually, I asked them, has someone told about protein? Did someone say low protein? Yes. Then I say, actually, I was also taught this, but now we know it is wrong. And why I'm saying this? Now, and it's obvious that patients are sarcopenic, although we can have formal nutritional assessments. And sarcopenia will lead invariably to frailty. So a frail patient is not going to be a candidate for transplant in any case. So that's why we have to do something about the nutritional status. So even I initially would have thought that this is part of the cirrhosis, but actually, no. If you'd ask exactly how much nutrition we should give, now the maintenance is 1.2 grams per kilogram per day. In sarcopenia, we should increase this to 1.5. So this is actually evidence-based. EASL, that's the European Association for the Study of the Liver, 2019, recommends 1.5 to 1.5. Now, if we really think that means what sort of food should we be recommending to our patients? If we take a 60 kilogram man and we give the maintenance dose, 1.2 grams per kg per day, that comes to 72 grams of protein. So that means all of the following: 1 whole egg, 2 egg whites, 1 palm size is not a small, stingy portion of fish. It means the size of your palm, a large piece of fish or meat, 1 cup of pulses, 2 cups of milk. So this all in a day is what the maintenance is needed for a person who doesn't have severe sarcopenia. So if you just think about, do our patients get this? And then we might think that actually this might be why the patients are so malnourished and doing so poorly. And then there is absolutely no place for talking about low protein, because you see, this is really what they need. Whether we can give this is another question, but we should all be actively encouraging and telling our patients about this. Each person who sees HO, everybody can make a difference, but we need a sea change of the way we think about giving nutritional advice to our cirrhotic patients. So calories also, we have to give adequate calories, and actually we have to be thinking how to improve their nutrition. So it's advised that a late night snack is recommended to meet the caloric and the protein requirements, as well as help their micronutrient deficiencies. They can have zinc and manganese deficiency, so supplementation may also be considered. And we were, of course, talking about obesity. So, of course, a lot of cirrhotics are obese, so that we have to change approach with things like with those people. So their energy requirement, we have to get them to lose body weight, and therefore we have to, this is the caloric requirement, and it has to be titrated to the ideal body weight. And even in obese patients, they may be having sarcopenia because it's difficult with all the fat to really assess their muscle mass. And we have to treat the treatable risk factors, and such as dyslipidemia, and statins are very safe and we should encourage them. We have to prevent them from further decompensation. For example, alcohol. Now, this is actually an old slide when I was working with Prof. Janaka. So it shows clearly that it's possible. Now, the red line is those people who are not abstinent. The blue line is those patients who are really abstinent. So if we really educate, explain to patients, if they really understand this, they will follow. So actually, when I was in Kurunegala, I had a ward, and then patients who come for upper GI could see on the other side all the complications that they will have to go through in the future. Ascites, encephalopathy, how many people are on paracentesis. So actually, if the patients do understand what can happen, and that they will listen, but we have to tell them that already there is a liver damage. With time, even if you stop, there's a small chance you will need a liver transplant. But that we can stop if you stop taking alcohol, or we can postpone the need of liver transplant if you manage to completely abstain from alcohol. Actually, people do abstain and they do really well, and some people can even come off the transplant list, but we have to take the time for it. And of course, this picture is, of course, excellent social distancing in Piliyandala in front of a bar, people getting ready for the New Year, the Vesak religious celebrations. So further, we have to stop further decompensation. So if there is a treatable cause, great. If we can give antivirals or steroids for autoimmune hepatitis or penicillamine, then we can reverse fibrosis. But it's a very rare case. So what we can do is prevent unnecessary drugs being given. Now, for example, if you go to a surgical ward, I mean, it would be almost impolite to come out without having diclofenac 50 milligrams BD. So remember, all patients who go for other procedure surgery, things like that, they must not be given diclofenac even in suppository form. We must prevent the decompensation, and really we can save their lives by not worsening the damage. Right. So patients on the transplant list, if they get a hepatocellular carcinoma, sometimes they may be rejected from transplant, or say if you're in the US, they may be expedited, but it's very important to know whether your patient has a hepatocellular carcinoma or not. So the guideline is screening with ultrasound recommended every 6 months with or without alpha-fetoprotein. Sounds very straightforward. However, if any suspicion, we must go for a triple phase CT. But I'm just going to show you this patient I had recently. So 2 very good consultant radiologists have done 2 scans. Both show no hepatocellular carcinoma at all, but there is a small hint that there is a portal vein thrombosis. His alpha-fetoprotein came as 11,000. So he was waiting MRI or CT, but his clinical condition was so fast that it progressed and he died before he could get the further imaging. So really, it's more likely that it's such an important thing to suspect and go behind the possibility of HCC. Then a lot of physicians sometimes ask, is paracentesis needed? Usually, if you ask the question, the answer is probably yes. It's indicated in all patients with new onset or worsening ascites. So if the patient is, and also all patients who are hospitalized with worsening ascites or any complication of cirrhosis. For example, they can come with an upper GI bleed, but they have moderate ascites. If you do a diagnostic tap, they may be having spontaneous bacterial peritonitis, because these things go together. So we have to be looking for that. If we diagnose SBP, that means patient can be on prophylactic antibiotics lifelong. There are things that we can do. So we should take a sample. Sample should be sent for a full report, neutrophil count more than 250, or pus cells 250 in our setting, diagnose SPP. Sometimes even a lower count I have to use, because we are not working in an ideal situation and patient may have been on some antibiotics before. Culturing, we should actually inoculate peritoneal fluid into a blood culture bottle. That is how we can get a positive culture, and of course send for proteins. So how to manage ascites? Good question. Restrict the salt. Usually we don't take time to tell about this. It's very, 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 very important, because if they stop the salt, the ascites and edema may improve. Previously, it was recommended very low salt, less than 2 grams. Now, sometimes there is some evidence that may be too unpalatable. So we may be considering for a little bit of moderate salt. But overall, salt restriction is important. We have to tell them what food they say. You tell them, and then they will finally say, yes, that's fine. But how about Marmite? So we have to really go behind the food that they are worried about and explain to them so that they will follow. And then we start, of course, sequential therapy. For the first presentation, we can start with spironolactone, but usually if these patients have edema, we need to add furosemide as well. This is the usual ratio, but we have to think of what the potassium is and the creatinine. Usually these patients have diabetes, going into CKD, the creatinine is high, the potassium is high, so really we have to monitor the creatinine electrolyte balance. And large volume, and for large ascites, we have to do a therapeutic paracentesis. And ideally, we shouldn't be worried of doing therapeutic paracentesis. It's something which is necessary, and ideally we should give albumin, and this is the amount, 8 grams per liter replacement. Another question asked from me is therapeutic paracentesis okay if there is a renal impairment? So the answer is yes. Now, for example, if you look at this stomach here, this patient is not going to get better without a therapeutic paracentesis. And also the large pressure in the abdomen will compress the renal veins and further exacerbate the renal impairment. So we do have to do paracentesis even if there is a small risk of a renal impairment. Another important thing is hyponatremia cirrhosis. Now, sometimes I meet so many SHOs who are suddenly worried that the sodium level is slightly low. But what we have to remember is this is part of cirrhosis. As patients deteriorate further, the sodium goes down. So much so that sodium is used with the MELD score to make the MELD score more efficient. So having a lower MELD means, having a lower sodium means that they are needing transplant more. It's part of their disease. So we cannot suddenly correct the sodium all the time, especially if they're clinical well. However, if they're symptomatic, that's another story. So we can reconsider the use of diuretics. But giving oral salt is not the answer. That's what I'm really coming down to. We can try fluid restriction, but we have to be worried of the risk of getting an AKI with hypovolemia. And if you have severe hyponatremia with fits, altered consciousness, things like that, then we can carefully use hypertonic saline. But remember, if you use hypertonic saline, we have to be very careful, because the normal for your patient may not be 135. It may be 128. It may be 130. So therefore, we have to be very carefully use, if necessary, really to help a neurological problem. So most important is, do not give oral salt, like a lot of people do. Why I'm harping on this is it happens, a lot of SHOs with great intention, on discharge, they give oral salt because sodium is low. I understand it's maybe a good intention, but what happens is invariably they get readmitted in 2 weeks' time with massive ascites. And also it really retards the education of the patient, because we have to say, now you should stop salt. And they say, no. Last time I was in hospital, I was asked to take 1 teaspoon 3 times a day. So it really, we lose our message. So please, let's all have one message regarding this. Another problem is, like, these patients will have to go for surgery, all sorts of things, and they will be given IV fluids, not for bleeding. So in this case, if you give a lot of saline, normal saline has a lot of sodium, and there'll be increase in the ascites and edema. So very important, when medical registrars go to see patients in surgical wards, you have to see how much saline has been going, and we have to restrict the fluids, and things like albumin and alternatives and oral hydration is better. But if we have to give 5% dextrose, maybe with insulin, or Hartmann's, if the potassium is okay, is much preferable. So let's say you do the TAP and now you find spontaneous bacterial peritonitis. So we all know third generation cephalosporins are recommended first line 5 days. We know. However, if the patient is not responding, that doesn't mean that's the end of the story. We have to step up the antibiotics. So for example, piperacillin, tazobactam, and carbaminoms are considered first line in areas of the world where there's high antibiotic resistance, and also nosocomial SPP. So we have to monitor the patient. So if the patient is worsening clinical symptoms, we have to think of stepping up. So actually we have to do a second paracentesis at 48 hours to see if the white counts are improving. And there should be at least a 25% reduction at this time. And don't be afraid to get the microbiology opinion, step up the antibiotics, because this is a treatable thing. This is something we can do. And also SPP, there is a benefit of giving albumin. This is a dose 1.5 grams per kg on day 1. And 1 kg on day 3. And of course, they should be on long-term prophylaxis. Another question is asked by my medical colleagues is, should there be considered SPP prophylaxis in primarily, or patients who never had SPP, should they be given long-term norfloxacin? So the answer is, when you do peritoneal fluid and find low albumin is associated with the risk of getting SPP. So this is from trial. And if it is less than 15 grams per liter and they have severe disease, more than Child's Pew 9 or bilirubin more than 3 with renal impairment, there is a place of giving primary prophylaxis for SPP. How about albumin? Now, if you go back to the picture of the bucket and we don't have many tools to really at our disposal. And we have so many patients. So albumin is kind of one that maybe we should be turning to, although it's slightly expensive. So then there are definite indications. So SPP, definite indication. Probably in hepatorenal syndrome, to correct the intravascular volume, good indication. So there are some which have sort of a controversial benefit. There are some trials which show a reduction in recurrent hospitalizations in patients given repeated infusions with albumin, but some trials have contrary evidence with no benefit. But what we know, what we have to say is, just because the albumin is low is no reason to give albumin. Serum albumin is 28, but patient is fine, no edema. Don't give albumin. That there is no indication there. But in a bad patient who has renal impairment, who has gross edema, you can't give diuretics. We're trying to do paracentesis. This sort of patient, albumin is something that you can fall onto. A quick word on vaginal bleeding. Invariably, these people bleed. So these are all patients from Kaluthara, and you can see and banding is essential within 12 hours, and sometimes some say even earlier. So, but banding also has to be a good banding, in my opinion. So basically, the endoscopist has to be experienced to find the focus and then band successfully. Now, if you look at this picture, you can see these are real patients in Kaluthara. You can active bleeding on the left side. So we have on the right side, you can see we have banded that exact site. And if you look at the picture on the right side, you can just see through the band cup, you can see that we have caught the ulcer from where it is bleeding. And even so in this. So after this happens, then the bleeding stops. But the problem is sometimes if it's an inexperienced endoscopist who's going in and just sees varices, just putting a band might not work, because if you don't catch the point which is bleeding, then you have put a band above or below that point and the patient is continuing to bleed. So this might be caused because about 1/5 of patients die due to upper GI bleeding, even in the best centers. So we have to really supervise and train our trainees, and we have to develop this. And even if you take a look at this now, here the bleeding has stopped, but you have to think where the patient bled from. So if you look closely on the right side, on the bottom, there is a place where there is a small plug where it has bled, and now the bleeding has stopped. But it's a very high risk that he will rebleed from this side. So we have to find the place and we have to rebleed. We have to band this point. But of course, we can't band a patient who is not adequately resuscitated. So it really falls on the duty of the ward to resuscitate adequately. So this is a medical emergency. So they have to get IV access, crystalloids, and they have to maintain a good blood pressure. Unless the patient is good enough, we cannot do anything. And actually, upper GI is not something that you can do in a rush. We need a bit of time to look for the place to band properly. And, actually in our setting culture, it's ideal in the A&E. We have 2 emergency physicians, and I have to thank them. Sometimes they resuscitate and they bring the patient and they come to the endoscopy and continue resuscitation while I'm doing the endoscopy. So that is ideal. And that is really the standard of care that we have to try to achieve, because if the resuscitation is happening adequately, we have more time on our hands to find the bleeding site and try to save the patient. So the target is 7 to 8, but this is really in a patient who is stable. If the patient is vomiting out blood, we don't have to say, no, here, we don't have, we have to, as much as blood goes, we have to be keeping the patient alive. We can give telepressin and octreotide. Now, thankfully, sometimes we have it in our hospital. So this is the dose, 2 milligrams stat and 6-hourly. Octreotide, there's a short half-life. So you have to give 50 mics followed by a continuous infusion. Some people give subcutaneous. There's no place for that. It has to be continuous infusion. But what is most important for anybody who's not doing endoscopy, that we have to give broad spectrum antibiotics. This has a mortality benefit. So like asking for upper GI, it's just as important that they are on antibiotics, and there is a proven 9.1 survival benefit. And remember, resuscitation has to be a dynamic process. Now, sometimes the HO will ask me, how many blood? Shall we give 1 blood, 2 blood? Is that enough? Now, the problem is it really is a dynamic process, because if the patient is going to collapse, we have to give more blood. It's something, and you have to have your finger on the pulse of the patient, literally. And if they're having a tachycardia, it's not a good show. If the BP is dropping, of course, then almost mature. And remember, the vitamin K, tranexamic acid, and IV omeprazole actually not proven to have a benefit, although we might use in a difficult patient. Beta blockers also not indicate, no, this is not for acute bleeding. This is a patient who is not bleeding. So if the patient has no varices, there is no place for giving beta blockers. Some people equate beta blockers and management of cirrhosis. So this is not so. If their upper GI shows no varices, we don't need to give any beta blockers. There is no prophylactic role there. Only if varices are seen, we give beta blockers. And also, and of course, in secondary prophylaxis, we have to eradicate the varices if they have bled. Beta blocker dose is very important. We have to titrate it up, trying to maintain a low heart rate, and we have to go to the maximum tolerable level. That's how we know that the pressure in the varices are coming down. Propranolol and carvedilol are sort of almost the same, but there is some evidence that carvedilol may be slightly better in those patients who are non-responders. We don't have to change patients who are on propranolol. Both are accepted, but carvedilol really seems to be slightly in vogue at the moment. One word of nitrates, we have to discuss, but these are the controversial things that I think it will be useful to discuss with general physicians. So previously, nitrates were added to beta blockers, and it was shown to reduce the rebleeding rate, but the trials were small and there was no overall survival benefit. So actually, a meta-analysis has later shown that there is no benefit, and instead of that, we are getting a lot of side effects of headache, things like that. So at the moment, owing to side effects and lack of data, ISMN is not advised anymore in clinical practice. another question, once the patient is really far gone, now this is a patient with a severe ascites. Now this patient, we don't want to, now the mean arterial pressure comes down in cirrhosis. So therefore, at the end of life, we don't need to somehow be giving that beta blocker because the blood pressure is coming down in any case. So there are mortality studies which show that propranolol has shown to shorten the survival in patients who are really far gone with refractory ascites. So we should stop the propranolol and go for a banding eradication program. A quick word on hepatic encephalopathy. So we had to treat the cause, sedation, sedatives, constipation, dehydration, infection. So these are usually nothing very new. We had to but make sure that the bowel is open 2 to 3 times daily, and we can give rifaximin or metronidazole. Both are okay. We can give metronidazole 200 TDS, that is adequate to get a gut sterilization. And there is some benefit for Lola as well. But what I want to stress is, now we can have this discussion about what are the effective treatments for hepatic encephalopathy. But if you take, this is a patient referred to me. So he was at the end of, I won't say which hospital, I have worked in many hospitals. So this is the patient at the end of the ward, near the bathroom. Not many people are seeing him. And if you look at his mouth, you can see that the mouth is full of secretions. So he is actually drowning in his own juices. He can't breathe, fully aspirating this patient. He needs to be sucked, chest physiotherapy, and actually, and of course, this patient died a few days after this. So this is, I took the photograph while the nurses were coming to suck, but this is really not adequate in our standard of care. So what I'm explaining is, we can talk about whether lactulose has evidence and things like that, or whether Lola should be oral or IV and things like that. But what is important is good nursing care to make sure that, because hepatic NCEF is a recoverable process. We don't want to let him die on our hands with a recoverable process because we couldn't turn the patient and give good adequate nursing care. So this patient should be kept in a left lateral position. And in this sort of situation, IV metronidazole is perfectly acceptable because it's excreted from the bile, and IV metronidazole will also sterilize the gut. So, yeah. So quick word on acute and chronic liver failure. It is a distinct clinical entity caused by liver failure. It is caused by liver failure due to an acute hepatic insult on top of cirrhosis. This has a very high mortality, over 50%, and the mortality is a 28-day mortality. And it's thought that acute insult will stimulate inflammation, systemic inflammatory response, cytokine storm, which will cause a central role in pathogenesis. So this is a slide from actually one of the review articles from Professor Sarin. So you can see that now the blue line is where the patient was. He was pretty compensated and doing fine. Then there's an acute insult there. Then normally he would have progressed and he would have been fine for a long time. But suddenly you can see that the liver function drops. And unless we sort of manage to get a recoverable cause and get him back, he will inevitably progress within weeks to multi-organ failure and death. This is a very serious thing, and it happens a lot. Sometimes we don't notice. Now, for example, so usually it can be something like viral hepatitis, so much so that we advise all patients to be immunized for viral hepatitis. We should be immunizing them for hepatitis B if the hepatitis B surface antigen is negative. All cirrhotics need hepatitis B vaccination. If the patient has not had hepatitis A, that is, if they are hepatitis A IgG negative, they need to be vaccinated for hepatitis A, so we can prevent this terrible condition from occurring. In all cirrhotic patients, it's something that it doesn't happen as much as we need to. So this is a typical patient. This is a young patient who took a lot of alcohol, probably for the new year or something like that. So, but what is important is they look like any cirrhotic, but the bilirubin continues to rise. So we've managed the upper GI bleeding, ascites, everything, but the bilirubin is just gradually creeping up. And what happens is, and I explained, like a MI patient will die within 24 hours, but ACLF patient will die within a month. What happens is gradually they develop edema, ascites, and the next week they will have encephalopathy, and about 2 to 3 weeks they are going to die. It's a very serious thing, and this is actually a true patient with ACLF and who passed away sadly as well. This is the liver functions on the right side. You can see the SGOT is 148, which means that he has alcoholic hepatitis. Alcoholic hepatitis, the SGOT doesn't go up too much. and that causes the bilirubin to go up. So a lot of times we worry about the SGOT, PT as markers, but actually that's not the problem. What is the problem is if bilirubin goes up in a patient who has chronic liver disease. And this one, actually, you can see it has gone 800 micromoles per liter. Normally it's 24, so 800. So so it is a really dire situation, and liver transplant is the only definitive therapy, and maybe abstinence or trying to relieve a cause, like withdrawing the cause or a causative drug. There are some possible experimental therapies we cannot really recommend. GCSF, steroids for alcoholic hepatitis, and plasma exchange. So actually, we do see quite a few patients in Kaluthara as well, and because we know they're going to die on compassionate grounds, we treat. Our protocol is to give GCSF for 5 days, steroids, and see if they're responding, and also offer about 3 cycles of plasma exchange. On a good note, I would like to, about risk of infection. Risk of infection is very, very, very high in all cirrhotic patients. This is something we can do. Not only SPP, pneumonia, UTI, you name it, they are sort of immunocompromised. In addition to that, they don't mount a very big immune response as well. So the CRPs might not be going as much as we think with their disability, malnutrition, and ability. So I have to give a case scenario. So I think the only general physician is Dr. Samita, the secretary. So unfortunately, you're going to have to answer the question. I'm sorry. So this is a scenario for Dr. Samita. 61-year-old male patient with a history of alcohol. This is a true scenario, right? So he was treated at a surgical ward at a very reputed teaching hospital. Again, I'm not going to tell where. So he had acute cholecystitis with abscess formation, and they managed, without doing surgery, of course, with interventional radiology, and they drained the sepsis. Now this patient has come. So the bilirubin was high, INR is high. Clearly, child C, if you go to analyze with this thing, gross ascites, shortness of breath. On ceftriaxone, white count is 14,000 on ceftriaxone day 5. He was told by his treating doctors that he will any moment arrest. And they told to please take him and go, sort of attitude, and that's what happened. So, if I might ask quickly. So, are we going to do a Glasgow stop treatment or give antibiotics? So actually, patient left against medical advice came to Kaluthara. Daily paracentesis for the ascites till the abdomen became lax. So we can make them comfortable first of all. If they have gross ascites, do paracentesis, make them comfortable. Then we can step up the antibiotics with this. He was given piperacin, tazobactam, and teicoplanin, and other management. So this is actually the same patient. 11 months later, no ascites, bilirubin normal, child's B, male score is less than 14 now. So this is actually a trick question because there were 2 recoverable factors there, which I didn't emphasize too much. First of all, there's infection, and infection will cause a cholestatic hepatitis. So just having an infection will drive your bilirubin up in any case. So therefore, the calculating the merit was not such a good idea at that time, and also stopping alcohol, and he's totally abstinent after that. So final slides. This is called the Raft of the Medusa, where in the 1970s, a ship was shipwrecked and 170 people escaped, and by the time they came to land, only 15 were surviving. Many of them died, dehydration, there was cannibalism, and many people died on the way. It sort of reminds me of what our patients go through waiting on the transplant list, because 20% of patients die waiting for transplant, even in the best centers. So we have to have good continued communication with the patient and the family. Is essential to balance the realistic expectations of the transplant versus the inevitable disease progression. And thank you very much to Professor Madhuri, who helped me with the slides, and our clinical nutritionist at Kaluthara. And I'm happy that News First is also trying to get to the truth of ascites. Thank you very much.
Thank you very much, Mananjala, for that wonderful lecture based on your personal experience as well. Also, thank you for focusing on the nutritional aspects, which we tend to neglect. Right, so we have come to the end of the 3 talks, and I think we have a few more minutes left for questions. Dr. Shamita will take over.
Yeah, thank you all the speakers for their wonderful lectures. And we got a lot of questions, but I will ask only the practical questions. And 3 questions to Professor Nirial. And one question is, what is the frequency of checking FIB4 score if it is less than 1.3?
Yeah, thank you for that question. It's recommended that we repeat the FIB4 yearly, once a year, and monitor these patients and get them when they exceed that cutoff of 1.3 for specialist referral.
The next question is, can we prescribe sodium valproate and carbamazepine for the patients with epilepsy who also have Nafl with increased AST and ALT?
That's a very tricky question. Usually in Nafl, you don't get a rise in bilirubin, and this enzyme elevation is not a contraindication to use certain drugs, but certain drugs which known to have sort of idiosyncratic drug-induced liver injury, we should avoid, because if the patient gets a idiosyncratic drug reaction on top of an apple, they will have severe disease. So the idiosyncratic drugs, drug-induced liver injury causing potential drugs should be probably avoided, but the dose-dependent ones can be carefully given and monitored.
The last question is, they are asking, what is the percentage of hepatocellular carcinoma in patients diagnosed with Nafl?
We don't have very good data from our setup, but we know that the trend is that the majority of the HCCs that we see now are due to Nafl. And the mechanisms that I have shown, there is a group of people with Nafl who rapidly progress to cirrhosis, and those people are the ones who present with hepatocellular carcinoma.
Thank you. The next question to Nilesh. And regarding bariatric endotherapy, would it correct metabolic disorder if the obesity is the only factor causing metabolic dysfunction?
So, if can you repeat the question?
Regarding bariatric endotherapy, would it correct metabolic disorder if the obesity is the only factor causing metabolic dysfunction?
Yes. So, if the obesity can be reduced, the metabolic dysfunctions can be reduced. So like I told you, the two interventions that we use, broadly, is the gastric interventions and the duodenal interventions. So the gastric interventions would be doing it basically by reduction of weight, and the duodenal interventions would be done independent of weight.
There's another question. Evidence on mortality benefits of the bariatric endotherapy.
I can't tell you the numbers offhand, but definitely, if you, common sense would be, if endobariatic therapy would reduce diabetes, would reduce Nafl, would reduce the basic metabolic syndrome, the different separate parameters, components, the mortality benefits probably would be there, definitely.
And two questions to Mananjala. They're asking whether can go ahead with the abdominal paracentesis if the patient is having hepatic encephalopathy.
Yeah, so that's a good question, but it really depends on the clinical scenario. Yeah, so actually it's not a contraindication. So what is important is, if the patient has gross ascites, he's uncomfortable, it's causing tense ascites, it's causing problems on the renal veins, this sort of patient is not going to get better if we don't tap the ascites. So if we are giving albumin and things like that, and in any case, hepatic encephalopathy is something that we can improve as well. So just because the patient has, it is a good question, but it is not a contraindication. If the patient needs a paracentesis, we have to do the paracentesis. We could limit the amount of fluid we take. Now, for example, you wouldn't remove 5 liters in a patient, but say you remove 1.5 or maybe 2 liters if there's tense ascites, then you can see how the patient will respond. So by the next day with the antibiotics, lactulose, bowel opening, the patient might get a bit better. Then we can go for a second session the next day. So we can do it gradually. But definitely it's not a complete contraindication, and we should actually we should encourage them to do paracentesis, I feel, in small steps and see the response. As the patient responds, we can do repeated paracensis. So a small amount to make him comfortable definitely is correct. It won't completely cause it. You have to balance the risk and benefit. Thank you.
This is the last question, Mananjal again. They're asking when to refer a cirrhotic patient to a transplant center.
Yeah, so that's a good question. So I think we might have to ask the transplant center before that. So ideally on paper, if the MELD score is 14 or above, we should be doing, at 14, we should be discussing transplant. If it is going above that, we should be referring to a transplant center. So sometimes I think the transplant centers, I think Madhuri will talk more than that, are overburdened with the amount of patients. So sometimes we may wait till the MELD score goes a little bit higher. Only problem is patients are also very educated and we have to respect their knowledge of things as well. So at 14, we have to start talking about it, explaining. Then we give them the option of going to a transplant. What happens is a lot of times we assume that the patient will get scared or that they can't do, so we don't talk about it. So I think we have to start the conversation there, and it's really the patient's wish to go to a transplant center or not. So we shouldn't deny that from the patient. It's our duty to talk about it, explain the pros and cons, give the option, and give it sort of a reasonable one. We don't want to depress them saying that they're going to die of liver failure, but we can say that there are options and that those things have developed now, and it's a good opportunity as well. Patients who have done transplant are doing very well. So we can give a balanced view and we can give them the choice. But MELD score 14 is really the cutoff. And definitely if it's going above that, we should be thinking of having the discussion for sure.
Thank you all speakers. Just because we are run short of time, we are going to wind up this liver symposium. And on behalf of the Ceylon College of Physicians, I would like to hand over the certificate of appreciation. May I call upon Professor Nirial to the stage. Dr. Nilesh Fananpulli. Dr. Mananjala Sena.
Right. So let's get on to the next part of our GI specialty day. And the first of the three lectures we have is going to be on non-portal hypertensive upper GI bleeding and evidence-based management. And to deliver the lecture, we have Dr. Udita Dasanayaka, consultant gastroenterologist from the teaching hospital, Batiklo. Over, Udita.
Thank you, sir. First of all, I would like to thank the CCP for arranging this event and the SLSG for giving me the opportunity to speak about this topic. So I'm going to talk about non-variceal upper GI bleed or upper gastrointestinal bleed, and is the special emphasis on evidence-based management. Just to outline what our approach is going to be, I will try to be a bit practical and just try to analyze the already existing practices that we see throughout the country. And first of all, we'll have to talk about the pre-endoscopic management, what should happen when a patient comes with upper GI bleed, with a special emphasis on resuscitation, risk stratification, and of course, pharmacological therapy, especially the PPIs. And of course, the endoscopic management about what the therapies, what the available therapies are, and what we can actually do to improve their outcome. And of course, about secondary prophylaxis, or what we should do after we manage the initial episode of bleeding. So, what we need to understand is that these patients, this is a very practical situation. When a patient comes with upper GI bleed, sometimes it's very difficult to, especially if it's a first presentation, it's very difficult to identify or sort of guess whether these variceal or non-variceal. So overall, just to go into the causes of the upper GI bleeds, I found this article from the UK this is one published in 2017, which helps to illustrate the various different causes of upper GI bleeding that patients can present with. So if you see, according to their data, the variceal bleeds, the portal hypertension related bleeds, varices and portal hypertensive gastropathy are actually quite a minority. And there are all these other causes like peptic ulcers, gastritis or erosions, esophagitis, erosive duodenitis, malarialized tears. So all of these things can present as acute upper GI bleeding. But of course, if you come to analyze some of our data, some of the one which I found was published by the NHSL group in 2010, it shows that in their numbers, a majority of them are portal hypertension related. So about more than 50% were actually portal hypertension related, and actually a minority was peptic ulcer disease related. So just to get more a little bit of more context on this, I went through our data, what our teaching hospital Batiklo, the cases we did with upper GI bleed over the last 4 months over this year. The total was around 52 cases, and again there was about 40% of them were either esophageal or gastric varices, and about 38% was peptic ulcers. And a large proportion, about 16%, did not have any demonstrable reason for the upper GI bleed. Maybe because of late presentation, because things like erosions and esophagitis, once the patient presents after having melena at home, maybe they have resolved, especially with PPIs. So there is a bit of a difference between the UK data and ours. So I would just, before starting off with the other contents, I will just go through the guidelines. So if you want to look into anything further or analyze anything further, or go through all this again, all these guidelines are available. The ESG guideline in 2015, the Asia Pacific guideline, and of course there's a recent American College of Physicians consensus update, and of course a very good state-of-the-art review in the BMJ in 2019. Right. So a patient presents with upper GI bleed. So what are the principles of resuscitation that we should stick to? So the first thing is hypotension. This sounds obvious, but hypotension is associated with increased mortality. So what by hypotension they mean a systolic blood pressure of less than 90. So there is, of course, obviously there's trial evidence for this. So what this means is that, of course, as one of our previous speakers also said, resuscitation is of the utmost important if someone comes with upper GI bleed. That is the most important thing. And of course, what to resuscitate with? There is no evidence that colloids are better than crystalloids, definitely. So you can go with crystalloids. And which crystalloid to use? So the guidelines suggest that balanced crystalloids might probably be better than normal saline. This is not from upper GI bleed studies. These are actually from critical care studies that showed that renal dysfunction and maybe the all-cause mortality is less with balanced crystalloids like Hartmann's. So better guess would be to go for Hartmann's. And of course, as mentioned previously, a restrictive transfusion strategy with a target hemoglobin of 7 to 8 is recommended. Now, if you look at different guidelines, it will say, one will say 7, one will say 8. So this is not very clearly defined. So again, this you should go with a case-by-case practical sort of your own analysis of the situation. And but generally, more than 8 in an otherwise healthy person is not really needed. Of course, there are exceptions. The first one is, of course, massive hemorrhage with hemodynamic instability. So the patient has lost a massive amount of blood. So the hemoglobin will not actually sort of reflect on the actual intravascular volume. And when you give crystalloids or when you resuscitate the patient, then the actual hemoglobin volume will be apparent. But by then it will be too late. So in that case, you will have to go for a higher transfusion requirement with emphasis on vital parameters rather than a hemoglobin. And of course, in cardiovascular disease patients, especially patients with ischemic heart disease, you have to go for a higher hemoglobin cutoff. Again, this higher hemoglobin cutoff has not been clearly written down, or it's not been clearly established. So most places it's 8 to 9. Some people recommend 10. So again, if the patient has active ischemic heart disease, if the patient is having angina, it will be, of course, common sense to go for a better correction of the hemoglobin or the intravascular status. So the other thing is risk stratification. So when someone comes with upper GI bleed, it's important to know whether this patient needs early endoscopy, whether this patient needs to be admitted, and whether the patient can be managed at home. So there are several risk stratification scores available, and of course the main difference between these scores are some need the endoscopic evidence or the endoscopic findings for their final score. So that sort of score, like the original Rockwell score, is not very useful for us practically. So the practical ones are pre-endoscopic scores. So the examples are the Glasgow-Blatchford score and the admission Rockwell score. But with regards to the Glasgow-Blatchford score, which is there on your right of the screen, I'm sorry if you can't see it properly, it takes into consideration the blood urea nitrogen. So if we want to do this in the wards, the main problem we have is these patients don't have a blood urea reading. So you can't apply this score in our setting. So it's important, if you want to do this, if you want to risk stratify the patients, you need to do a blood urea on admission. So which score is better? So if you look at your right, there is a graph which compares all the scores, the sensitivity and the specificity. And this has compared the need for intervention, transfusions or endoscopic therapy and the 30-day mortality. So what is shown here is the Glasgow-Blatchford score has shown more sensitivity and has been proven more accurate in predicting the prognosis of the patients who come with upper GI bleed. So use the Glasgow-Blatchford score if you are using a risk stratification score. And all the guidelines are in a consensus that if the GBS is less than or equal to 1, these patients can be managed as outpatients. So they can be discharged and may be seen at a later date and then arrange an endoscopy on an outpatient basis. Right. So now we come to a bit of a controversial issue, which is the proton pump inhibitor. But if you go across our practices, what we see daily, it is a given that someone with no history of cirrhosis, no clinical findings suggestive of cirrhosis, who comes with upper GI bleed, will invariably get high dose proton pump inhibitors. You will get a 80 milligrams loading dose and an infusion. So has that been proven to improve mortality? That is the question. So the short answer is no. So there have been several randomized controlled trials and they have not shown any effect on outcome in people who are using the PPI infusion against people who are not. So the outcomes in the sense rebleeding, need for surgery, mortality, there is no difference. But what it does reduce is once you do an endoscopy on a patient who was on proton pump inhibitors, it shows that it reduces the stigmata for bleeding. So maybe it controls the bleeding at the source level, and it will also improve the need for early endoscopy. So if you go through most of the Western guidelines, especially the NICE guidelines and even the American ones, they do not recommend pre-endoscopy proton pump inhibitors in patients with upper GI bleed. It's mainly because of cost concerns. So it's mainly because cost. It's not because it does any harm. It's because they want to save up on money. But practically, especially the Asia Pacific guidelines are quite practical in this sense. So what they highlight is that PPIs may have a role before endoscopy, especially if the endoscopy is delayed. So if you feel that you can't do an endoscopy within 24 hours, then this controlling this stigmata for bleeding and the reducing the need for early endoscopy, so those all come into importance. And of course, that part of things have not been evaluated. So all guidelines say if you have a feeling that, or if you feel practically that the endoscopy will be delayed more than 24 hours, then that is enough reason to start on high dose proton pump inhibitors and an infusion, right? So because we are talking about evidence, the most recent evidence, like the major evidence study done on upper GI bleeding and a drug, was the tranexamic acid study or the HALT-IT study, which evaluated tranexamic acid. This was a very high dose of tranexamic acid. It's like 1 gram of infusion followed by 125 milligrams per hour for 24 hours, because what is known about tranexamic acid is that it should be given early to have an outcome. So early you give it, the better. So, but this study actually included upper GI as well as lower GI bleeds. But a majority, about 90%, was upper GI bleeds, but upper GI bleeds also non-variceal plus variceal bleeds. Well, the bottom line was this study did not show any benefit with high dose tranexamic acid in GI bleeding. it actually showed that the numbers, of course, the outcome numbers were actually remarkably similar, except for venous events like pulmonary embolism, DVT. There is a slight increase in venous events, although numbers were less. There is almost a doubling with tranexamic acid, which is to be expected, I suppose, considering how it acts. So their conclusion was that tranexamic acid does not reduce death from GI bleeding and should not be used as part of a uniform approach to treat GI bleeding. So that was with regards to tranexamic acid. So there is no place for that at the moment. Okay, so now we have managed the patient. We have done the initial resuscitation and maybe considered pharmacological treatment. So the next question is, how soon do we need an endoscopy? So what the gut instinct is, once the patient comes into an endoscopy vomiting blood, comes into the A&E vomiting blood, to rush the patient to an endoscopy unit and get the endoscopy done as soon as possible. So is that correct? So all guidelines say that most patients who are admitted with upper GI bleeding should undergo endoscopy within 24 hours. That is, if it is practically available. But very early endoscopy, less than 6 hours, may worsen outcome in high-risk patients. So is there evidence for this? Yes, there is. But this study was done in 2016 in Denmark. But please note that it is only patients with peptic ulcer bleeding. So they have selected only patients with peptic ulcer bleeding. So it clearly shows, when the patients are, all the confounding variables are considered and, the mortality is compared, that early endoscopy may have less benefit than at around 24 hours. Of course, this needs to be taken with a pinch of salt, because this is not true for all patients who come with upper GI bleed. So if the patient comes with variceal bleed, if the patient is a known cirrhotic coming with variceal bleed, then as soon as you stabilize the patient, as soon as the patient is stable enough, then if the endoscopy is available, you should do it. But if you try to rush the patient as soon as possible, as mentioned earlier by Dr. Mananjala in the previous lecture, if you are in too much of a hurry to get the patient into endoscopy suite, then the patient might actually suffer because of that the poor resuscitation. So that is something to keep in mind. So once we do the endoscopy, what do we do? So this is just an example, because most of these guidelines sort of deal with patients who have ulcer bleeding, because that is the thing that is quantifiable and sort of classifiable. So when we see an endoscopy, when we see an ulcer on the endoscopy, we use the Forrest classification to stage the ulcer, which stages the ulcer from 1 to 3, and there are also subcategories as well. So there is evidence that any ulcer which is above 2A, 1B, 1A should be dealt with endoscopically. Something should be done to control the bleeding from those ulcers. Of course, for 2B, the adherent clot ulcer, that is sort of on the fence. So sometimes you can just manage with PPI. But the thing is, if you do an endoscopy, if you see an adherent clot on an ulcer, then we more often than not do something about it. But of course, the ulcers with the 2C and the 3 ulcers we can manage medically without any endoscopic intervention. So what I wanted to highlight here is that, again, as said in the previous lecture, it is not the importance of doing any endoscopy. It is the importance of doing a proper endoscopy, because someone who is doing the endoscopy should be able to identify the ulcer or the lesion, and then sort of have an understanding about what to do depending on what you find. So the endoscopic management methods that are available to us, the most commonly used one is the adrenaline injection, 1 in 10,000, or some people use 1 in 20,000. But again, this should not be used alone. So what they suggest is, once if you give an adrenaline injection, because the effect wears off after say 24 hours, then you should use another complementary method to make sure that you achieve hemostasis. So the other options are thermal coagulation, contact thermal coagulation using probes, or non-contact using things like APC. And of course, we use clips, through the scope clips, which can be applied directly on bleeding vessels or to approximate the edges of the ulcer. And of course, there's some literature on sclerosant injection, although it's not very commonly practiced. Just to demonstrate an example, and this is a sort of a pyloric ulcer with bleeding vessel in the initial endoscopy, which had been managed by clips. So sometimes we have to apply a lot of clips to get the control of the bleeding. So this is a follow-up endoscopy which showed that the clip was in place, but the patient had continued to bleed despite this optimum endoscopic intervention. So in those sort of cases, we have to think about other options available. The most important one is the radiological or the interventional radiological approach. So if you look at the final picture, you can see that they have done an interventional radiology and they have embolized the gastroduodenal artery and control the bleeding. So we always need to, the resources, we have to be available of the resources available, and we have to be ready to move on to the next step. So just to mention the newer endoscopic modalities, although it's mentioned as new, even in Sri Lanka, in some centers, we have been using this for the past couple of years or even more than that. So one option is the over-the-scope clip. With the previous clips I mentioned are going to be passed through the endoscope. But these clips are sort of placed over the scope tip, and then it's used to approximate the ulcer edges and control the bleeding. And the other thing is the hemostatic spray, the hemo spray or the endoclot. There are several trade names. So this spray, once it's like sort of a last resort. If you can't, if it's the area is too big, or if you can't control the bleeding properly, then what we do, this spray can be used, and it will sort of form a coagulum by using up all the clotting factors and the platelets and control the bleeding. But unfortunately, this is not a permanent solution, because usually the clot will wash off in about 48 to 72 hours, and then the patient may need further intervention after that. So there was an earlier practice of a second look endoscopy, so maybe after 24 to 48 hours, a repeat endoscopy to look if the initial therapy was successful. But now the consensus is that if the patient is not bleeding, and if you are satisfied with the first endoscopy, then you don't need to do a routine second look endoscopy. Right. So the next question is what we need to do as secondary prophylaxis. So now all the guidelines recommend that the PPIs should be as a secondary prophylaxis. It's very well established. So they suggest that the patient should get 80 milligrams, the loading dose, followed by 8 milligrams per hour for at least 72 hours following successful endoscopic therapy. So this would mean that the patient would have to stay in ward for 3 more days to receive the IV proton pump inhibitor. Although some guidelines suggest that the IV twice daily dosing is as effective, but again the Asia Pacific guideline, which I feel is more practical, they have suggested that the high dose oral PPI for 3 days may be an alternative. Although there is no evidence for this, there is no randomized control trials. There is some evidence. There is some evidence that studies done in South Korea and in the Orient, they have suggested that this is equally beneficial. And the PPI therapy should be continued for 4 to 8 weeks. This is not evidence based. This is sort of has been the practice for a long time. A very short discussion of antiplatelet and antithrombotic drugs, because this is a lecture in itself. It's too big to handle as a subtopic. But the bottom line is, the main thing you need to do is, it should be considered on a case-by-case basis. And if possible, if the patient is high risk, you should get other clinicians who are managing the patient also involved. But aspirin can be restarted once hemostasis is achieved. So the thing is, if the patient is, for example, if the patient is on a drug-eluting stent, if you leave the patient without any antiplatelets and see what happens, then the stent can clot in about 7 days, that median about 7 days. But if you just put aspirin, that can be maybe increased 10 times or more, that survival of the stent. So aspirin, if the patient is on dual antiplatelet, that means that the patient really needs the antiplatelet. So the aspirin can be restarted once hemostasis is achieved. I'm sorry, there's a spelling mistake there. The dual antiplatelet, the second drug, may be delayed for 5 to 7 days, depending on the clinical situation. And again, warfarin. it's again a different sort of a topic, but restarting of warfarin can be considered early if there is high thromboembolic risk. So again, this is a case by case basis. This does not mean that all patients should be started within 7 days, but if you have a high thromboembolic risk, then you can consider that, provided the endoscopic management had been successful and the patient is stable. So that brings me to the end of the things I wanted to discuss. So in summary, what the main thing is, once the patient comes, the Glasgow-Blatchford score is the preferred risk stratification method. But if you want to do that, you have to do a blood urea. You can't do it without a blood urea. And resuscitation is more important than super urgent endoscopy at presentation. So please remember that, resuscitate the patients and then arrange for a proper endoscopy, because a timely endoscopy by a competent endoscopist can prevent further complications. So that is an important step in the management. And I have not given a conclusion about the PPIs as primary therapy, but of course the general consensus is that if the endoscopy might be delayed for more than 24 hours, you are more than within your rights to start the PPI. There is no harm and there might be a benefit. But PPIs are the most important drug for secondary prophylaxis. So just because we are on the topic of endoscopy, I just wanted to highlight that the SLSG have put out endoscopy guidelines, especially in the current new normal setting, and that it is available in our SLSG annual newsletter. So if you want to go through that, you are more than welcome. Thank you very much.
Thank you very much, Udita, for that excellent lecture, focusing on the guidelines and keeping us abreast to what's happening. Do we have any questions?
We'll go for the next lecture.
We'll proceed to the next lecture in the interests of time, which is going to be on IBD. IBD, as you know, is increasing in our country, and the topic we have selected today is IBD in Sri Lanka, emerging trends and clinical implications. To speak about this, we have Dr. Isrujit Liyanage, who is the senior lecturer and consultant gastroenterologist at the Faculty of Medical Sciences, University of Sri Jawadanapura. Over to you, Isrujit.
First, I'd like to thank the College of Physicians and Sri Lanka College of Gastroenterology for giving me this opportunity. Chairperson, sir, I'm really glad to be talking about this topic, which is an important and an emerging condition in Sri Lanka, and we are expected to see more patients in the future. So during these 20 minutes, I'm not planning to go into details about the disease itself, of which the clinical and management details you're very familiar with. I'm going to talk about the uniqueness of the Sri Lankan perspective and how our patients are different. And in that context, I believe our registrar colleagues who are listening would also get some additional information. So how common is this in Sri Lanka is the first question. And Sri Lanka is one of the few countries in the region with good quality data on prevalence and other features of inflammatory bowel disease. So we have a few good studies that are being carried out in Sri Lanka, and one by the Ragama Gastroenterology group led by Professor Niriyala, who's present today, and another one that I'm quoting here is from Kandy. The overall prevalence that we are looking at is about 10 patients per 100,000 of the population. And these studies have found that about 20% of these patients at the time of diagnosis were delayed or rather missed at initial presentation and were found later on in an endoscopy. And now when I said 10 per 100,000, if you look at the Western data, they are looking at numbers exceeding 100 to 200, and in the Orient, especially in the Mongoloid populations, it's about half of that. That's about 50 to 100. And we know there's a lot of data to suggest or support that in developing countries and in South Asia, the prevalence is increasing. So we expected to see a lot more patients in the future. Further, the sex distribution, when it comes to ulcerative colitis, it's slightly more predominant in females than in males at a ratio of 3 to 2. And Crohn's disease is more or less similar in numbers between the sexes. The gist of this is that unlike a lot of other autoimmune diseases that we treat, inflammatory bowel disease is present in both sexes. So that is the lesson for primary care doctors. And age at diagnosis, it's it's in the mid and the late 30s in Sri Lanka. This is about 5 to 10 years later than what is the age at diagnosis in the West. This also supports the fact that we probably pick these patients a little later than we should. Now, why is it important to talk about this condition? One is that this affects younger age group and it causes significant disability. In contrast to early detection and management, and properly managing these patients would kind of restore them back to their normal livelihood. That is something that we need to compare with a lot of other chronic diseases where treatment probably would leave some disability, but this is a condition that if we detect early, we can do a lot of benefit. And there's a lot of cost for medical and surgical care, hospitalization, etc. if disease is complicated, and especially if biologics were needed and surgery and prolonged hospitalization is needed. So what can we do to detect these patients early, and why are we missing a certain amount of patients early in the disease is the question of the day. Now, inflammatory bowel disease can present in two ways. One is an acute classic presentation that we all know about, where there is when it comes to Crohn's disease, there's abdominal pain and significant weight loss and increased bowel frequency and so on. Whereas that presentation is only seen in about 30% of all patients across the world. And in the few literature that we have in Sri Lanka, it's only seen in about 15% of the patients. Whereas there's a much more indolent and a milder disease presentation where the patients would come with, when it comes to Crohn's disease, would come with slight increase in their bowel frequency, sometimes not even qualifying to be called diarrhea, and a little softening of their stool consistency. An abdominal pain, it may not be very severe, may not be colicky, might be a small abdominal discomfort that is often labeled as irritable bowel syndrome. So what is important here are these hard features which I've mentioned here. They are the weight loss, anemia, generalized ill health, and also other extra-intestinal manifestations. Those are the things in the presence of those milder gastrointestinal symptoms that we should suspect and channel these patients for further investigations. Now, when it comes to ulcerative colitis, the typical presentation is with bleeding or passage of bloody and mucoid stools. Now, again, that full-blown presentation may not be seen in all the patients, and only about 15% of the patients presented with acute episodes. And another common symptom or representation that we often neglect are the rectal symptoms. That is, the patient having tenesmus, urgency, sometimes incontinence, especially with a little bit of passage of a little bit of mucoid bloody stools. And interestingly, about 5 to 10% would complain because of this rectal symptom, would complain of constipation, along with a little bit of incontinence, as I mentioned earlier. So it's very important to detect these patients early. And also, now when the disease is more proximal in the bowel, now when it's distal in the bowel, they'll have these rectal symptoms, they'll have passage of frank blood, but when the predominant disease is more proximal in the bowel, stools are going to get mixed with blood. And in that context, about 20% of the patients, if you look at the literature, will not have noticed that they had blood in their stools. It's rather dark brown stools that they pass at a higher frequency. So it's very important to look at these subtle symptoms and suspect the patients to have inflammatory bowel disease and direct them for further investigations. And that will probably help us to detect these patients early. I'm not going to explain this slide a lot further, but the main message is that Crohn's disease, compared to ulcerative colitis, has an extensive footprint. So it has a lot of other extra colonic manifestations, extra intestinal manifestations, especially with perianal disease and then upper GI involvement. There are a lot of strictures that can take place, and then a lot of systemic symptoms are also there. So when it comes to systemic symptoms, we call them extraintestinal manifestations, and then looking at the Sri Lankan data on extraintestinal manifestations. Some form of arthropathy was seen in about roughly about 25 to 30% of patients in Sri Lanka. In one study, and another study reported a lot higher values, about 60%. Ocular symptoms, that is mainly uveitis, episcleritis, etc., were seen in about 10 to 15%, and skin manifestation in about 6 to 8%, and axial arthropathy in about 7%. So these are the common of the extraintestinal manifestations, common to inflammatory bowel disease in general. Now, if you look at Western literature, these values are about half of this. This also supports the fact that we are picking these patients a lot later, and also we are picking only the complicated patients. Right. An approach to a patient, the first and foremost thing is to diagnose, as we discussed until now. And there are investigations, especially basic investigations when it comes to hematology and stools investigations. Hematological investigations would support or favor further investigations. There'd be presence of anemia, iron deficiency, low albumin, and then stools investigations. This is something that is important for us to exclude, or rather, which has a negative predictive value, that is low CRP or absence of inflammatory markers, along with stool calprotectin. So, stool calprotectin and stool lactoferrin are kind of emerging as very important tests for inflammatory bowel disease. We use this to exclude or kind of to negatively predict inflammatory bowel disease, but we also use stool calprotectin to look for treatment response. So 99% of the time you can with a fairly confidently state that active inflammatory bowel disease is unlikely if these two are normal. So endoscopy and histology are the mainstay of diagnosis. So when it comes to that, the message is that it should be performed by an experienced center and properly done. Especially we come across a lot of endoscopies where they have only biopsied the affected area and they have not performed a biopsy series. And then the pathologist as well as the treating clinician comes kind of, the diagnosis is based on the extent, severity assessment is based on the extent and the continuity of the inflammation in the bowel. So it's very important that proper endoscopy is performed and a complete biopsy series performed. And if there is a suspicion, to do an ileoscopy and to reach the ileum when it comes to endoscopy. And the message with regards to histology is that compared to malignancies, where the histology is the definitive diagnosis, inflammatory bowel disease, histology is it is one of the most important things, most important diagnostic tools that we have. But histology per se cannot be the complete answer to the question whether there is inflammatory bowel disease or whether it is inflammatory bowel disease or not. So sometimes there are situations, about 15% of the time, that where we are not 100% sure whether it's inflammatory bowel disease, and also whether it is in ulcerative colitis or Crohn's disease, and we are sometimes unable to, based on all these criteria, still unable to classify it as one entity. And then finally, there are some investigations that we do to determine the disease extent and also to screen for complications and also to see if they are suitable for certain treatment modalities that we use. So there is a place for imaging at the presence of in the hands of an experienced radiologist. Even an ultrasound can pick certain bowel pathologies. But what we use commonly in Sri Lanka are CT scans and specialized MRI scans to look for, especially when it comes to Crohn's disease, to look for strictures and other complications within the bowel. So next thing that I want to discuss, so after diagnosis is severity and markers of poor outcome. So this is important for us to plan initial management to see how intense or how hard we're going to hit these patients to achieve a remission. So when it's very severe, we try to admit the patient and give high dose or more intense induction therapy, and also markers of poor outcome as well as severity would help us to determine how well we are going to manage them, the intensity of our follow-up with regards to immunosuppression and further management. So this is achieved by all these modalities. There's no single tool to diagnose or to kind of determine the severity and outcome of all entities of inflammatory bowel disease. So we use all these entities, clinical, endoscopic, histological, as well as the response to treatment to determine these factors. So I'll briefly mention a few other tools that we use. So for ulcerative colitis, clinical determination of severity, Truelove and Witz came up with this criteria in 1955, more than 60 years ago. And there are a lot of other tools that are used, and I've listed all the factors that are used in different tools. So if you look at them in general, we are looking at with regards to ulcerative colitis, we are looking at the stool's frequency, we are looking at bleeding, we are looking at the general well-being of the patient, and we are looking at rather evidence or outcomes or features that tell us that there is a systemic inflammatory process going on. And finally, extraintestinal manifestations. So if they are present at a higher level, we kind of label it as severe disease, and when it is severe disease, we know that the outcome can be more sinister compared to milder disease. Milder disease can be managed at home, whereas moderate and severe disease ideally needs to be hospitalized. Albumin has a special place in this context because albumin is, of course, a negative inflammatory marker. So when there's a systemic inflammatory process going on, albumin tends to be low. These patients sometimes, especially when it comes to Crohn's disease, would be malnourished. Therefore, albumin is low. But albumin is also lost from the gut during inflammatory bowel disease, and we use albumin as a marker of poor response to treatment, especially when it comes to biologics. Biologics being a protein is also lost from the gut. So when people with low albumin, when we give them biologics, their serum concentrations are a lot lower than other patients when their albumin is low. So we use this as a marker to predict that. Crohn's disease is slightly more complicated when it comes to determining the severity. As I mentioned earlier, it has a wider footprint, so it has a lot of systemic manifestations. It's a bit difficult for us to kind of in a very simple way to look at the severity and markers of poor outcome. So we use some clinical indices. CDAI, or Crohn's Disease Activity Index, is widely used, but it's very complicated to calculate. Harvey-Bradshaw Index is relatively simpler, and it looks at these features. So if we just want to list them out so that you'd know what are the things that rather point out a poorer prognosis or more severe disease course in these patients. It's general well-being, abdominal pain, and the number of liquid stools per day, abdominal mass, and presence of one of these complications, mainly extraintestinal manifestations. So we look at this to determine the severity and also to look at the response to treatment and also to detect recurrences and relapses. So Crohn's disease, you'd probably come across this. It's called the Montreal classification. We use this to kind of label or classify Crohn's disease. Again, earlier age at onset, and location beyond the colon, behavior when it comes to kind of other than inflammatory behavior, that is stricturing and penetrating disease, and also when it comes to children, impairment or rather kind of interference with growth. Those are the features that suggest a more severe and disease and a poorer outcome. So this is called Montreal classification. So sometimes you would come across this saying A2, L3, B3 Crohn's disease. So that's an internationally accepted way of classifying the disease. So when it comes to Sri Lankan patients, again, I'm quoting a study carried out by Ragama Gastro group, looking at the morphological characteristics of inflammatory bowel disease. So all these complications are a lot less than what we observe in the West. If you look at the steroid refractory or dependent patients, we're looking at about 1%. When it comes to the West, it's about 5 to 10%. And pancolitis in ulcerative colitis is seen only in about 30% of these patients. So fortunately, our patients at the moment, the population are kind of demonstrating a much more milder and a milder disease course and a less amount of complications. Again, there are markers of poor predictors that are internationally used, but when it comes to Sri Lanka, a lot of these markers were less less valid when it comes to our patients. But in summary, in Sri Lanka, this study found that low age at onset, severe disease at onset, and having a family history of inflammatory bowel disease and presence of extraintestinal manifestations and higher socioeconomic status, doing a better job, coming from a better educational background, carried a poorer prognosis. Right. So finally, I'm going to talk a little bit about the future of investigating inflammatory bowel disease. I mentioned earlier that we do not have a single diagnostic marker or a tool. So there are serological testing that have been widely discussed, both ASCA and ANCA. Current evidence are not in favor of this, so it's not recommended anymore. Genetic testing has a lot of potential. There are a lot of genomic or other alleles that we are testing that both for diagnosis, assessment of severity, and also to assess treatment response and which modality of treatment to use. Currently, the evidence is not to recommend any routinely, except for in clinical trial situations. There are a lot of new novel biomarkers that are currently being tested, and fecal volatile organic metabolites are one of them. But still, none has kind of emerged yet on a commercial level for us to use clinically in our settings. So, in addition to what I've mentioned, mainly clinical suspicion, basic investigations, endoscopy and histology, and then finally imaging. There's no definitive diagnostic marker or a tool at the moment for inflammatory bowel disease at the moment. Now, when it comes to IBD and genetics, there are a lot of genetic variants of IBD, because we have noted that about 30% across the world, about 30% of all the patients with IBD will have a very mild disease course. They would, some of them, about 10% would have what we call a monophasic disease progression, where just have a single flare up or an episode, and they would have a rather remission, lifelong remission. So the tricky part is to detect who are kind of going to have complications in the future, who are going to have a mild disease outcome, and to decide how to treat, because treatment, especially when it comes to immunosuppressives, have a lot of side effects and other complications. So we have an excellent study again carried out by Ragama Gastro Group, where they looked at genetic associations of inflammatory bowel disease in Sri Lanka. They compared about 400 plus patients with equal number of healthy controls, looking at 16 commonly previously identified nucleotide polymorphisms that are genetic markers. And that found that a lot of genetic markers of poorer prognosis or a complicated disease process across the West are not present in Sri Lanka. But in contrast, some of the, kind of interestingly, some of the markers of better outcome or rather milder disease course were present in Sri Lankan patients. So in summary, IBD in Sri Lanka is a grossly underestimated problem, and we at least miss about 20% of our patients due to lack of suspicion and channeling towards further investigation. So clinical suspicion is very important, and currently identified patients in Sri Lanka have a less severe GI-related disease course, but more systemic and extraintestinal manifestations, mainly joint-related disease manifestations. Genetic analysis found that Sri Lanka have a different genetic makeup. Now, this is interesting because this kind of calls for more local evidence on management and outcome of these patients. And treatment is highly evolving, and based on current case numbers, our best, or rather, in an ideal situation, should be planned at least at specialized gastroenterology units. Now, surgery, I did not mention about surgical care for these patients. So we need surgery, especially for complicated perianal disease and sometimes complicated colonic involvement, where it goes into toxic megacolon, where they need colectomy. And there are emerging surgical evidence that especially for isolated ileocecal Crohn's disease, excision can kind of provide a very good outcome. So in the main message is surgical care should be provided in very experienced centers. That is the recommendation across the world, because management of a perianal condition, especially an abscess or a fistula, due to Crohn's disease is quite different to management of an abscess or a fistula in the absence of Crohn's disease. So it should be managed in a specialized surgical unit. And that's all that I have to mention. Again, I would like to thank the College of Physicians for giving me this opportunity.
Thank you very much, Surujit, for speaking about the landscape of IBD in Sri Lanka. We next move on to our final lecture for the day, which is on colorectal cancer. As you know, the incidence of colorectal cancer in Sri Lanka is increasing, while as in the West, there is a decreasing trend. And this is mainly due to colorectal cancer screening in the West. To speak more on this, we have Dr. Chamila Subasinghe, who is the consultant gastroenterologist from the District General Hospital, Kegol. Over to you, Chamila.
Sir, and good afternoon, everyone. And thank you, College of Physicians, for giving me the opportunity and highlighting this topic as a rising with a rising importance. So the outline would be an overview, when to start and stop screening methods, and quality of the colonoscopy, and few take-home messages. So you might know already that the CRC, which is a colorectal cancer, is the third commonest cancer in males and females globally. So which is following lung and prostate cancers in males and females, mainly the breast and cervix. So it's very common in the European part of the world and Australia as well as, and we are somewhere in between of the incidence, just above the African countries. So we have some local data. So that date back to 2008. It's from Ragama professorial unit. So they have studied the prevalence of colorectal cancer and survival of patients in the Gampaha district. It's close to 400 patients. So at the initial part of the 1990s, and the incidence was 1.9 per 100,000, but towards 2004 it has risen. In males about 4.9 and females about 3.2 per 100,000. And the median age of presentation is about 60 years. And interestingly, about 28% has been detected to have in less than 50 years. And the majority of these cancers has been from the rectum and rectosigmoid, the left colon. So that time the flexible sigmoidoscopy has been offered as a useful screening tool. And from the same center, a couple of years later, so again, the majority of the left-sided cancers has been detected. And again, more than 25% of all CRCs has been detected in less than 50 years of age. And again, the median age at diagnosis was 62 years. So you can see the graphical presentation here. So the most of the age group between 50s and late 60s. And this from Kalubowila, and they have identified the need of having a screening program, a colorectal cancer screening program in Sri Lanka, because they found out that the at-risk population is about 12.5%. So this been suggested in 2018. This is a poster done presented in this society meeting in 2017. This is from Colombo professorial unit. So they have compared the National Cancer Control Program data with the neighboring countries in Indian Cancer Registry and the Karachi Cancer Registry, and found out that the CRC was the 4th and 6th commonest cancer among males and females in Sri Lanka respectively. And the incident rate is rising and reaches peak around 60 to 65 years. And interestingly, the compared to the other two entries in India and Pakistan, we had more incidence of colorectal cancer. And more interestingly, single-use population is found to have a higher number of CRCs for unknown reasons. And this is the latest one, which is also showing the 2001 it was 2.9 per 100,000, and 2010 it is about 6% per 100,000. There's a proportional increase of colorectal cancer, but also observed to be greater in females than earlier years. So this is a graphical presentation that you can clearly see the rise. So this is the latest one, like the Global Cancer Observatory, which is the data from March 2021. So it is the fourth common cancer in Sri Lankans, and found out that it's the third commonest in males and fourth commonest in females, right? The initial years it was about 6th and 7th position. It just now became to much higher level now. So what are the risk factors? The heavy consumption of alcohol, high consumption of processed meat, age, which is being 50 years old, male gender, low calcium intake, obesity, smoking, and family history of colorectal cancer. These are the well-proven cancers throughout the world. So why the argument of screening? Because CRT is highly curable with 5 years satisfactory with good survival, and 90% of these are localized disease, and 70% of them have a regional disease, and only just about less than 10% of them having metastatic disease. So it's very important to have an initial screening and diagnose these, because we can provide a very good survival for these. And most of these cancers, more than 80%, occurs in average risk. It's in general population. And out of those, 70% start as adenomatous polyp, like in sporadic. And 30% of them have in a sessile serrated lesion, which is a different type of polyp, which is flat actually. And the important thing is there are no reliable early symptoms, and therefore you have to go for the screening. And it should aim to remove the adenomas and sessile serrated lesions and detection of early stage colorectal cancer. This is the prime aim of screening. So I'll just show few mechanisms, mainly the main mechanisms of developing colorectal cancers from a polyp. So the conventional adenoma carcinoma sequence, and the serrated pathways and the familial pathways. The diagram is for the adenoma carcinoma sequence. So with the activation of various genetic mutations, such as in a normal colonic mucosa, finally become an advanced cancer. So the leftmost picture shows how the normal colon is. Then when the process advances, the rightmost one shows the advanced cancer. So when to start screening? The average risk individual, which is between 50 and 75 years. It's been proven by a lot of studies. It's the recent most data I took from the American College of Gastroenterology publication. So it reduces the incidence of advanced adenoma, cancers, and mortality from CRC, which is a strong recommendation and moderate quality evidence. And screening beyond 75 years, it should be as on individual basis, depending on the risk factors. And if you have a family history of colorectal cancer or any advanced polyp with high-grade dysplasia or villous features, size more than 1 centimeter. So if you have one first-degree relative less than 60 years of age, or 2 or more first-degree relative at any age, the screen should start with a colonoscopy straight away at 40 years of age or 10 years before the youngest affected case. For example, if you have a first-degree relative with the diagnosed colorectal cancer or advanced polyp at 45 years, the screening should be starting the rest of the members in 35 years. And the interval should be every 5 years. In other scenarios, like one if a first-degree relative more than 60 years of age, any second-degree relative, they should go back to the general average risk cancer screening. So when to stop, that's also important. So average lead time from adenoma to carcinoma, which is about 10 years. So you have to consider the life expectancy and benefit from surveillance. If you go beyond 75 years, you have to consider those aspects as well, and whether this the therapy will be effective, whether we can prepare these patients for proper colonoscopy preparation side effects, and the adjustments of the anticoagulants, and then so many factors to consider if you consider this beyond 75 years of age. So generally between 15 to 75 years, the screening group is recommended. So what are the screening methods we have? We have stool-based test, blood-based test, and as well as the direct visualization tests. Stool-based ones are the guaiac-based fecal local blood. The other one is immune-based immunochemical form, which is also called as fecal immunochemical testing, and multi-target stool DNA test. So blood-based, there's a thing called Septin9, not widely available. And we have the direct visualization test as well, which is the colonoscopy, is the gold standard, the flexible sigmoidoscopy, CT colonography, and the colon video capsule. So earliest evidence come in 1993 that clearly shown screening for colorectal cancers using fecal local blood has decreased the CRC incidence by 33%. This was a large study including around 50,000 people. And later on studies, they also have shown the similar result, that showing the clear reduction of colorectal cancer mortality through screening from fecal local blood. How to screen? So tests that detect cancer, fecal local blood they can detect. Tests that detects adenomas plus adenomas or cancer, colonoscopy, flexisigmoidoscopy, or even CTC colonogram. If above average risk, directly you have to go for the colonoscopy, the high risk patients. Otherwise, you may be many of options of approaches, like you can go for colonoscopy first, you can go first for BT, later colonoscopy, or mixture of test. So few things on stool-based test. The guaiac-based form, which is we commonly use in Sri Lanka, which is very cheaper. And the immunochemical form is also being used in certain areas, a bit expensive. And MTS DNA test is not being used. So important is those are non-invasive one, can be done at home without any risk of complications. And thing is you have to do it several times, like at least 3 times. Even one is positive, you have to go for colonoscopy. And it has the low sensitivity to detect earlier adenomas. So sometimes maybe even advanced adenomas might not be detected from conventional stool test, except is the DNA test, because it detects fragments of DNA from a tumor cells in the polyp. And this has to be repeated annually. So it's cheaper and widely available. And it identifies hemoglobin in stool through a peroxidase reaction. And it is not limited to human heme, because it can be positive when you eat ingestion of meat. And also get false positive in NSA juice, and even iron supplements get cross reactions with this test. And when you take vitamin C also, it might give false negative result, because its antioxidant action might inhibit the color reaction. So these confounding factors we have to consider and need to stop those at least 3 to 5 days prior to doing this fecal blood testing. So immune testing, this specifically detect human hemoglobin. There's no interactions like in guaiac form, and therefore it's the preferred one. So there's a randomized trial comparing these two, FIT versus guaiac form, and it has shown it detects more effectively all the cancers, adenomas, relatively significant numbers in immunochemical testing. So recommendations for 2021, colonoscopy and fecal immunochemical testing should be used as the primary screening modalities for colorectal cancers. And screening tests for individuals who are unable or unwilling for a colonoscopy or FIT, so might be flexible sigmoidoscopy, or multi-target stool DNA test, CT colonography, or colon capsule. Except for this MTS DNA test, others are available in Sri Lanka. Septin9 should not be used, which is a blood-based test, because it has low sensitivity, which is close to 50%. So colonoscopy, it's considered as the gold standard, and it allows complete examination of the colon and resection of polyps and biopsy from the suspicion lesions. And it is the final common pathway for all screening programs. And it has 100% detection rate of colorectal cancer, provided the preparation and the technique, everything normal. And reported incidence of post-colonoscopic cancers is about 3 to 9%. And there's a significant reduction in long-term cancer recurrence incidence also while using colonoscopy as a screening method. So it has been shown in evidence in large numbers. So prevention of colorectal cancer by colonoscopic polypectomy, multiple studies. So limitations would be high cost, may not be the factor in Sri Lanka because it's widely available. And which is operator dependent, that may be a factor when you're doing the procedure, and which requires bowel preparation plus or minus sedation, and it is not without any risk of complication. There is a slight risk of complications like perforation, bleeding, but still it's very low in very experienced hands and trained hands. They have compared colonoscopy versus fecal testing, whether to which is better. But found out that the colonoscopy group had lower participation rather than the stool testing group, and both had similar cancer detection rates. Both had similar, but adenoma detection rate is much better in colonoscopy. So there may be options. So patients might not like it, but you have to discuss and proceed. What makes up a good detection? Obviously, the bowel preparation. We categorize according to the Boston Bowel Preparation Scale, mainly using your researchers. So, poor bowel preparation will obviously have a higher rate of mislesions, and that we should target at least 90% of the time have a good colonoscopy. This for this preparation. And adequate time of examination and the technique, which is like looking behind the colonoscopy fold, which is properly cleaning up the stool puddles and adequate distension of the lumen. So everything makes a difference. And a central gaze type of looking in the monitor. So when you consider the bowel preparation, the split dosing has clear benefits by identifying the adenomas and even the early stage cancers. So left picture shows how the non-splitted bowel preparation. So the right picture shows how the split preparation acts. Splitting the preparation means the day of the preparation is administered the day before and the day of the procedure, rather than everything given on the day before. So it has shown that adenoma, advanced adenoma, and even sessile polyps has been much detected in split preparated group. So obviously the training, the lesion recognition, withdrawal techniques, so the withdrawal time is globally accepted as to have at least 6 minutes. This is without any intervention, like the time taken for polyp removal, and so it's separately taken. But you should have at least 6 minutes of examination during withdrawal. And the problem we detect in our country is the poor documentation of the procedure. Of course, most of our centers doesn't have photographic documentation facilities, but we should have it in the future. So documentation is very important, and the visual gaze pattern. How do we achieve excellence in training? So utilize high quality colonoscopists, like should be able to quote ADR, which is the adenoma detection rate. So preferably in male patients, it should be more than 30%, and in females, it should be about more than 20%. At least 25% of ADR is acceptable, and they should have a split preparation, and should have a photographic documentation of the cecal intubation. We'd have a cecal intubation rate of at least 95%, which has proven in trials. And they should see appropriate use of follow-up exams. And very importantly, switch from GWAC FOBT to immunochemical form of testing. So, and like it's been used in 20 years ago, they avoid digital examination to detect cancers, right? Are there technical solutions to for this variable detection? Especially for the flatulation, we use various techniques, and various techniques is coming from various endoscopy companies. So the chromoendoscopy, as in first image, there may be it has a place to use the flatulations. So narrowband imaging, blue light imaging, and the eye scan, those are the various techniques has been used, but there is a limited data and some are having mixed results. So to see the hidden mucosa, especially behind the folds, like whether there's importance of having cap fitted at the distal end of the endoscope. So probably may be useful, but it still show a mixed result. Specialist training standards. Some might not like this slide also, but this is consistently proven over several years. Actually, endoscopic training standards differ by specialty. Studies show how gastroenterologists do better always. The 5 times the non-G doctors are 5 times more likely to miss the cancer, and the non-G, they are doing the procedure having 80% of more interval cancers over 3 years. And surgeon, even the colorectal surgeon, there's about 40% more interval cancers within 5 years. So it has clearly shown that the gastroenterologists do better. So CT colonography is kind of a virtual colonoscopy. This is how you see the images like this as it is shown in right. So which is less invasive, less complications than colonoscopy, which does not require sedation. It has about almost 100% sensitivity for cancers, but variable sensitivity for the other downgrade polyps, and a poor sensitivity for flatulations. So the limitations is positive result definitely require a colonoscopy, and it requires bowel preparation. That means you have to, if it is positive result, you have to do twice bowel preparation, which may not be a good ultimately. And radiation exposures. So the graph shows how the cumulative risk of having cancers with the recurrent radiation exposures, and incidental extracolonic findings. So that is also a problem. Actually, if you find some clinically non-significant extracolonic lesion, maybe additional workup for the healthcare system, and also a limited availability for trained radiologists for this purpose. This is also a problem for our country. Colonic capsule, it's a small capsule with a camera and battery and memory, and the batteries inside. It can be swallowed, which has no radiation and no extracolonic findings. It doesn't require any sedation and can be done at home, even at GP level. So it has more sensitivity and specific for the polyps more than 6 millimeters. But again, the problem is, if you have a positive finding, you have to again prepare for colonoscopy. And repeating test interval is also unknown because of the cost. Flexible sigmoidoscopy is also a good option in those days, but now there's so much of evidence that it examines only the left side. There are large part of the colon remain unexamined, so probably not the best thing in these days. Only very limited scenarios you might use this. So recommendations continue. Follow-up intervals for screening modalities. The fecal immunochemical testing yearly, colonoscopy every 10 years, FlexiSig in about maybe 5 to 10 years, multi-target stool DNA test every 3 years, colonography in 5 years, capsule in every 5 years. So they have a very conditional type of recommendation. So what about interval cancers? Colorectal cancers is rarely detected within 5 years of normal baseline endoscopy. So they mainly arise from missed lesions, about 50%, and new lesions, about 24%, and importantly, incompletely removed lesion is about 20%. And about 8% of cancers, they also they result from missed lesions at colonoscopy, especially done within 3 years also. So these are the association. You see the serrated lesion as I have shown in the picture, which are flat polyps you might not see at a glance. So might need special techniques to use, or clear the careful examination of the colon. So serrated lesion in more proximal location and MSI, microsatellite instability positivity and CMP positive. Those are the association which for interval cancers. And colonoscopy done by non-GI doctors, and colonoscopies with low adenoma detection rate, low cecal intubation rates, and low polypectomy rate. So misscreening interval, all these factors the associate with interval cancers. So post polypectomy surveillance, when you get tubular adenomas, few 1 or 2, less than 1 centimeter, they can be followed up as the usual screening, like 5 to 10 years. But now the adenoma number is more with the tubular histology or any villus component or any high grade dysplasias. The surveillance interval should be shortened. And if you have a large sessile adenoma, which is a removed piecemeally, at least twice a year examination should be recommended. Recommendation for 21 continues, and the idea of having low dose aspirin in individuals, especially between 50 to 69 years, with the predicted 10% prediction of cardiovascular disease over next 10 years, and no increased risk of bleeding, and those who are willing to take aspirin for the next 10 years, is recommended to have low dose aspirin also. So this may be balanced with the other the effects, and sometimes the severe dyspepsia might restrict the use of this. And it has clearly shown that there is a benefit of preventing colorectal cancers, but it should not be used as a substitute for colorectal cancer screening. And we recommend the organized screening programs to improve the adherence to colorectal cancer screening, other than the opportunistic screening in future. So, few take-home messages. Colorectal cancer incidence is rising globally as well as locally, and it is highly curable disease and easily preventable with a good more than 5 years survival. So most occur in average risk individuals with no early symptoms. Therefore, the screening is the only way out. And preferably it should start from 50 years of age. Like in global data, we also have the local data as well. Our incidence is median incidence of age is about 60 years. So starting at 50 years, 10 years before would be a reasonable thing. And wide range of screening methods available in Sri Lanka even for the moment. And attempts should be made to shift from GUAC form of FOBT to immunochemical testing. And the colonoscopy is the gold standard and the endpoint of screening, and should be done by properly trained colonoscopists. So this will improve the future incidence of colorectal cancers, and the rising numbers of trained specialists in this field also, I think probably it will have a good impact in our future. So I would just summarize the few important aspects. This from a European study group. So thank you very much for the opportunity.
Thank you very much, Chamila, for bringing us up to date on colorectal cancer screening. Thanks for the great lecture. I'm sorry we don't have time for questions for the last 3 speakers, as we have gone overboard. I will like to wind up this GI update. First, I would like to congratulate all the 6 speakers for giving us some fantastic lectures. Congratulations and thank you. Also, I would like to thank the Ceylon College of Physicians for organizing this GI update, and like to present the certificates for the last 3 speakers. On behalf of the Sri Lanka Society of Gastroenterology, I would like to thank the audience for their participation. And would Samita like to add something?
Yeah. Thank you, Sanjeeva. And on behalf of the Ceylon College of Physicians, I would like to hand over the certificates of appreciation. May I call upon Dr. Udita Dasanayake to the stage? Dr. Isurujit Lianake, please. And Dr. Chamila Subasinghe. Now we have come to the end of this symposium, and on behalf of the Ceylon College of Physicians, I would like to thank Dr. Sanjeev Arisinghe as well as the president of the Sri Lankan Society of Gastroenterology. And we had the collaboration for the month of May with the Sri Lanka Society of Gastroenterology, and we had three excellent programs. One was the college lecture. We started with the college lecture, and yesterday we had the expert webinar, and today the last one is the specialty update. So again, Sanjeev, thank you very much, and your team for collaborating with us, and we will be meeting again in future with the other events. And also on behalf of the Ceylon College of Physicians, I would like to thank the staff of the ClinMark, as well as the staff of the Ceylon College of Physicians CCP office, and also our audiovisual team. And finally, I would like to thank our sponsors. And we will be meeting in the next month with the Respiratory College. Thank you so much.